That's true. I think that would be the idea. That's normal. That's normally what happens, you know. I think Alain's having a wee bit of a panic because he forgot to bring his connector with him to connect his presentation with our apparatus. I think so, Carolyn. You know, there's Mark back in now, and what's that?
Just be with me.
So we'll get at the laptop.
Good morning, everyone. Margaret, is the mic working okay? So good morning, everyone. It's my pleasure to welcome you all here this morning to the launch of the South Eastern Trust Community Mental Health Perinatal Service. It is my pleasure to welcome our Director, Margaret O'Kane, to the podium to formally open today's proceedings. Margaret first became Director of Adult Services and Healthcare in Prisons in May 2020, having previously led the Trust's Disability Services. As Director, Margaret has been a huge support in the development of the Community Perinatal Mental Health Service. Indeed, I have benefited from Margaret's guidance, not just through this project, but across many areas of service development. Margaret, can I invite you to come and open the conference?
Thanks very much, Damien. Can you hear me okay at the back? Yeah. I really wasn't expecting those few kind words. You've sort of thrown me a wee bit now. Gosh, what a start to a Tuesday morning. Isn't this just incredible to be here? So many people for such an amazing reason. It just feels so privileged. It's wonderful. So I'm delighted to welcome every single one of you here today. And for those who can't join us but are joining us remotely, you're very welcome as well, and we're sorry you're not in the room with us. Delighted to welcome you all to the launch of the South Eastern Trust Community Perinatal Mental Health Service. And I can't believe I'm saying that. It's brilliant. It's so exciting. Really delighted to see such a wide representation from multidisciplinary colleagues, not only from South Eastern Trust, but from the other trusts as well. And I mean, I really feel that I should say, it feels like we're getting this off from the right start. It's not about what one trust is doing or another. It's about how we can work together across the region. A fabulous example of support from all our colleagues, colleagues also in primary care, PHA, Department of Health, Ulster University, community and voluntary sector, and particularly people with lived experience. I don't need to tell you that the need for perimental health service in the region has been long recognised, and there's been extensive lobbying and awareness raising over the years by some very dedicated people. We wouldn't be here today if it wasn't for those individuals and organisations, and I just feel definitely have to name a few. So Lindsay Robinson, Dr. Janine Lynch, Shauna Hamilton, PHA, in particular Dearbhla Webb, and finally Minister of Health Robin Swan, who committed resources to develop these services. Alongside these individuals, there have been many community and voluntary organisations that have also campaigned for specialist perinatal mental health services in Northern Ireland, particularly the Maternal Mental Health Alliance groups, Aware NI, led by Tom McEnany, and the Royal College of Psychiatrists Perinatal Faculty, led by Dr. Julie Anderson. My pages are stuck. It's well documented by Embrace that one of the leading causes of maternal death in the first postnatal year is suicide. And we're aware from learning and recommendations generated through serious adverse incidents that this is a crucial service, and we know from existing perinatal mental health teams that are established throughout the UK that there are clear improved outcomes for women and their babies and their families when perinatal mental health services are involved. Within the South Eastern Trust, a number of individuals, and in particular Damien Brannigan, and I'm not just saying that, Damien, because you said nice things about me, Stephanie Patton, Dr. Paddy Moynihan, have all been instrumental in driving forward the recruitment, development and implementation of our perinatal service. This has enabled us already to offer all perinatal women with severe and complex mental illness a specialist community mental health service, which is multidisciplinary, trust-wide, equitable, accessible, and close to home. I'm so proud to be associated with such an important development, and I have to say I'm a bit in awe of the work that has been done to date to make this service a reality. And the passion in the room and the enthusiasm is just electric. I'd like to extend to everyone associated with this new perinatal service my very best wishes for success in delivering best outcomes for those mothers, babies and families who will be supported by the services moving forward. So very well done to get this far, and good luck for the future, and thank you.
Thank you, Margaret. Good morning, everybody. Victor Robinson's my name. I'm the coordinator and co-chair of this conference launch event. Could I just take a small opportunity to say thank you to all those who worked with me as a team to create what's here today. It's been a long time coming, but we got there in the end. So without further ado, you'll get to meet all of the team later some way down the programme. But our first keynote speaker is Dr. Alain Gregoire. Now, those of you who are boring like me and watch BBC Two might be familiar with Dr. Alain Gregoire because he's the presenter of Trust Me, I'm a Doctor. Would you trust him? So Dr. Alain Gregoire is from England, so thank you for making the journey here, Alain. Very much appreciate it. We know how difficult it is to get you to speak. There are so many people trying to do that, and we're very grateful that you gave us your time to share your wisdom about perinatal mental health. You're very much the expert, and we are really attentive to listening to what it is you've got to tell us. So Dr. Alain Gregoire, he's been a consultant specialist perinatal psychiatrist for 30 years, during which time he has set up and led multiple national award-winning specialist perinatal mental health services. He has contributed extensively to the development of policy, strategy, guidance, and clinical services in the area of parental and infant mental health in the United Kingdom and across the world. He was the founder and is president of the United Kingdom Maternal Mental Health Alliance, an organisation, I would have to say, as Tom McEnany, I'm sure would support me in saying, was very instrumental in supporting the plight for perinatal mental health services in Northern Ireland. I first got to meet, not in person, but online, Dr. Gregoire at the conference you organised, Tom, for Aware NI. He is, as I say, he was the founder and is president of UK Maternal Mental Health Alliance, and he has successfully campaigned for government funding for perinatal mental health, not just here, but right across the United Kingdom. In 2016, he launched the Global Alliance for Maternal Mental Health and has supported the development of successful alliances in many other countries. And as I say, Alain is also a BBC TV presenter for the award-winning programme, Trust Me, I'm a Doctor. Gives me pleasure to introduce you, Alain. Thank you very much.
Great, thank you very much.
Speak close to the mic for the online streaming.
Yeah.
People here will hear you.
Cool, brilliant. Well, thanks very much, Victor. And it's just wonderful to see so many people in this room, all dedicated to perinatal mental health in Northern Ireland. I think the first time I came over to Belfast, there were about 3 people in the room who were saying, yes, we're going to make things really change here. But that was many years ago, actually. So it's such a joy to be here. And I think there are somewhere in the ether loads more people watching in, or I hope there are, from all over Northern Ireland, and probably elsewhere as well, because, of course, this, even though you may think you've been waiting for years for this to happen, and you're way behind other places, you absolutely are not. Worldwide, you are in the forefront, the absolute vanguard of development of perinatal mental health care. You know, psychiatry is coming of age. Mental health care is coming of age. We are now seeing the need for expertise and speciality because of the level of knowledge in mental health. When I was a medical student over 40 years ago, surgeons in a surgical list would do a mastectomy for breast cancer, a gallbladder operation, and some heart arterial cardiovascular operations, the same surgeon in the same list. Can you believe it? Now, medicine and surgery have come of age. We expect people who know what they're doing and know what they're talking about to be delivering healthcare. And mental health is now becoming the same. We have experts in a range of different areas of mental health care because just doing everything is not good enough. It's not just touchy-feely, make it up as you go along. And perinatal mental health care is a really brilliant example of that. It can only be delivered well by dedicated people who are dedicated to doing that work, who are trained to do that work, have the skills and the knowledge to do that work. And that applies right across the pathway, from primary care all the way through to the specialist services that are being launched today, or that is being launched today. So we need education and we need training, and these events are the kind of start to what will be lifelong, ongoing training for people working in the dedicated services, and should be part of the passing on, their role in passing on information and passing on skills and knowledge to the rest of the system, the rest of the pathway. So if we could have the first slide. I'm used to having a button, but I have to just ask for the next slide. And this is just to illustrate the Maternal Mental Health Alliance, from whom I send greetings, from all over 100 organizations that work nationally, either in one of the nations, but most of these organizations working across the UK. And you'll see one organization in particular, next slide, or press the button. Yeah, no, back. Yeah, one organization in particular. Have you seen that girl? And of course, Lindsay Robinson, who's been doing this amazing campaigning work in a dedicated way for Northern Ireland services. And there she is. She's not in the room, I take it. Is Lindsay in the room? No. But anyway, well done, Lindsay, and of course, all the other people who've worked so hard, and I'm looking at a few, and you know who you are, to get this to happen. So really magnificent effort, but we are learning rapidly in England, where developments of teams are a little bit ahead of you, not much, that this is fragile. So yes, there's a great fanfare, yes, there's a great commitment, yes, the trusts are really proud of you, yes, the national people are really proud to be here, and it's all wonderful, but when push comes to shove, if A, you don't deliver fantastic care, which there is no problem in doing in perinatal mental health, because they're fantastic people, and there's a fantastic need for it. But if the money starts to get tight again, people start thinking, well, where can we take it from? Where isn't it very important? Oh, women and babies, that's just touchy-feely and cooing and eyeing. We need to do serious mental health care. Well, that, of course, as you know, is a complete misunderstanding. But that sort of thinking does creep into people who sit in front of computers with pound signs in front of them, making choices about where those pounds get distributed. So we've got to make sure that our services are felt, that the quality and the fantastic service they deliver is felt, and that people understand what they're about. So your work isn't over yet, campaigners, but we now have the deliverers working alongside us. So next slide, please. So what will women get from a service like this fantastic one that's in the process of being set up? Well, I've mentioned expertise, absolutely critical, and this won't hit the ground running. You cannot expect to recruit people newly into specialist perinatal services and have them be experts instantly. They have to have the training, and to have training, of course, the funding has to be there in a dedicated way, easily accessible, with time for training, and the training needs to be ongoing. If you are the absolute last stop for getting access to expertise, then you have to be on top. And the knowledge is developing very rapidly. So we have new literature being published all the time in perinatal mental health worldwide. It's now a big area of academic research. And it's not just expertise about maternal mental health. Of course, it's mother and baby mental health. And so we need to understand the development of the baby's mind, and in particular what that development relies on, which is the relationship with its primary caregiver. And in Northern Ireland, like most other Western societies, in fact, most societies across the world, whether it's PC to say it or not, the primary caregiver at that age is usually the mother. Not always, but usually the mother. And the mother is particularly at risk of mental health problems. And we'll come to why and how in a moment. So absolutely critical that there's expertise in the mother and the baby and the attachment, the relationship. And all of those need care and expertise, and we'll get it with the specialist service. Detection, important role, because we know that the majority of women with mental health problems, particularly the common mental health problems, the majority are not detected, and we know that there are long delays before people with severe mental health problems are detected. And in perinatal, we can't afford long delays because the clock is ticking. And so we have to build systems that ensure that as soon as somebody is getting ill or starting to get ill, or even if they're at risk of getting ill, that we know about it and we're actively doing something about it. This is not a situation where we can wait the 12 to 24 months average detection time for, say, schizophrenia. Not acceptable in perinatal, in fact, quite ridiculous. Accurate diagnosis, so not just understanding the problem and describing it, but getting the diagnosis right. Why is this important? Well, for certain diagnoses, there is no time in life when it is so important to understand the nature of your problem, and I'll touch on that in a moment, because the risks are higher than at any other time in human existence, and I'll come to that. So getting that diagnosis right is critical, and it is one of the tragedies of modern mental health care that you can look through the records of patients and find no diagnosis mentioned from one year to the next, and in some cases ever, in severe high-risk problems. In my view, that's unacceptable, but that is a very common situation across mental health care in the UK and other parts of the world as well. And this is not possible in perinatal. You have to get it right. Effective and rapid treatment. So, you know, we have a reputation in mental health care, when you look across the whole health system, of being a bit slow and lackadaisical and things take time. In perinatal mental health, you cannot take time. You've got to be on the case and you've got to see results. And the mums want to see results, but more than anybody, the babies want to see results. And we'll come on to that. The diagnosis issue also relates to recognizing the difference between mental illness and mental injury, which is not a term you see referred to very often. What is mental injury? Well, mental injury is very similar to physical injury. It's trauma, and it's probably the most common cause of mental health problems. In fact, certainly the most common cause of mental health problems, and yet we don't talk about it like that. But we should. It's very different treating a heart problem, chest pain due to a myocardial infarction compared to chest pain from the tip of a knife starting to pierce the heart. Very, very different treatments. And the same applies to the difference between mental injury and mental illness. Very different approaches to treatment. And we need to recognize that, but particularly in perinatal, where we're seeing transgenerational mental injury taking place and an interaction between mental illness and mental injury, we need to think very carefully about this, because we may need to deal with both, and we may need to deal with both across several generations. This may sound a bit scary. Actually, what it is a wonderful opportunity that we are given, this generation, from this knowledge, to do something about something that has been affecting humanity since the beginning of time, or since the beginning of humanity. So really, fantastic news, and you now have the means to do it. Across the whole of the pathway, there is a role for the specialist services to have dedicated time to not just see the patients in front of them and to go looking for the patients in front of them, but to ensure that everybody else who is supporting those patients is well supported themselves, but is also supported in the rest of the work they do, looking after people with common mental health problems, because it is within the specialist service that specialist expertise lies. And those other professionals and those other, for example, third sector organizations across the system will rely on the specialist knowledge of that local service. So it needs to be able to give that knowledge, and that time and effort needs to be acknowledged by the system. And that includes, of course, reducing stigma, ensuring there's information, as well as improving care. And it's great to see on the Future Plans poster commitment to quality, continuous quality improvement. And in perinatal, we probably have one of the best systems in the world for continuous quality improvement, acknowledged worldwide, which is the Royal College of Psychiatrists Perinatal Quality Network, which, although it's run by the Royal College of Psychiatrists, is absolutely multidisciplinary, whole team effort. And in England, it's part of all contracts for services that they must be members of the quality network. And I very much hope that from the moment this team is set up, and since it's already set up from now, it becomes a member of the network. Do not wait until you can meet all the standards. The whole point of quality aspirations is that you join when you're not meeting standards so that you can build up to doing so. Can we have the next slide, please? Okay, so this is a traditional pyramid of care which we use as a way of understanding healthcare needs and distributing services. And in mental health, we talk about severe illness, of course, and we talk about moderate and mild illness. And in mental health, we fall foul very regularly of assuming that that relates to suffering. Okay, and burden of disease. It absolutely does not. Okay, what that talks about, what the severe means, is high risk and complex need for complex multidisciplinary care. So people may be suffering just as much at the mild to moderate end, and in fact we know that in terms of public health, the burden of disease from the so-called mild to moderate, the burden of disease to humanity, is much greater than at the severe end. The most burdensome disease known to man is depressive illness, common depressive illness, mild to moderate depressive illness, because it recurs or it's chronic, it goes on and on and on over a long period of time. And so it is extremely disabling in terms of life years lost. And so we mustn't kid ourselves that we're in mental health, I'm a psychiatrist, us in our specialist team, we're dealing with the severe stuff and other people are dealing with the kind of the trivia. It's not trivial. The bottom of the pyramid is the biggest proportion of the population. Can we have the next slide, please? Yeah. No, back. Okay. It's a bit difficult. I want the overlay is what I should be saying, I suppose. Anyway, click the next button. So the tip of the pyramid, yes, needs complex, expensive, multidisciplinary care and is high risk of death, high risk of very acute, very disturbed illness, but most of the burden of disease is held in the bottom of the pyramid. So yes, the expensive services need to make sure that they're delivering care to only those people who need expensive, complex, multidisciplinary care, but they should see it as their responsibility to ensure that everybody across the pyramid needing perinatal mental health care gets the right sort of care, which means not doing it yourselves, but helping the other people in the room here, working in primary care, health visiting, maternity services, to make sure that they're equipped to deliver to that other 90%, and not forgetting third sector voluntary and community services who are absolutely critical to this endeavour, not because they're free and cheap and we can't afford to do everything, but because they do things through, for example, peer support that professionals cannot do, are not capable of doing. It's a different sort of approach, a different sort of care, and it complements what professionals can do. Next slide, please. Right, okay, just a few facts. So I know you're all familiar with these facts, but let's just reiterate them. They're kind of in the lift conversation. Well, what do you do? Oh, is that important? Yes, you can say, this is really important. You know, the most common major health complication of maternity is just one of the mental health conditions, depression. And people might say, oh yeah, but those other conditions, you get blood on the floor with hemorrhage, you get women dying dramatically with preeclampsia. Well, of course, as you've already heard, the main cause of death after 6 weeks is suicide, and overall the main cause of death in maternity is our mental health causes of death. If you just, so ignore Africa and South Asia, just look at the pale blue, you can see the scale of the challenge with depression. And of course, I have another slide where I colour in the depression in red and the others in blue, and that's because there are dedicated maternity services that are just for looking after those other conditions and reducing risk, but there aren't those for perinatal conditions across the spectrum. Next slide, please. And this is also the highest time of risk for psychosis in human existence. There is no other time when psychosis is so prevalent as in the first few days after childbirth, and it only affects women. Next slide, please. There is no time in human existence when if you have a bipolar disorder, when you are at such high risk of developing an episode as in the immediate postpartum period. And most postpartum psychoses are probably or are variants of bipolar disorder. Although some people are more at risk, next slide please, are more at risk, next slide please, are more at risk in the postpartum period. So in that top left picture, you can have these slides afterwards, so I'm whizzing through them, but you can come back to them if you like. Women with bipolar disorder who've had episodes outside the postpartum period are at risk throughout pregnancy and postnatally, but that blue line, which you can barely see during the course of pregnancy, is women who've only had postpartum psychosis ever, and who only appear to be at risk in the postpartum period, not antenatally. I won't dwell on the other graphs for the sake of time. Next slide, please. So look at these 4 photos. What do you think they have in common? Suggest some things. Okay, no, you're wrong. Babies, yep. Actually, they do all have, one of the photos hasn't got a baby, but they have got a baby. They're smiling, yeah, they're all smiling, which is interesting, yeah. But that's not what I'm looking for. What have they all got in common? They all have, at the time the photo was taken, or recently had a postpartum psychosis. One's the odd one out. Which one? Come on, odd one out. Any suggestions? Some of you will have seen this slide before, I think. No? No suggestions at all? Well, one of them hasn't got a baby, one of them hasn't got a partner. In fact, they've all got babies, they've all got partners. The one at the bottom right is the odd one out because she's still alive. The other 3 died because of their postpartum psychoses, and all of them had inadequate care in areas of the UK where they didn't have specialist services. And they're all smiling, and actually all 3, the photos were taken during their psychoses, which is telling, isn't it? These were extremely ill, highly distressed women, and yet they managed to force a smile for a photograph. Bottom left was a consultant psychiatrist. And she stabbed her baby and then set fire to herself in the throes of her psychosis. So these are awful, awful conditions that affect people in the prime of life at the most critical time in human existence, when we're reproducing, when we have the next generation to look after. Next slide, please. And if you take all psychiatric or mental health causes of death, these are the leading cause of maternal death in the UK and have been for at least documented for 20 years. And yet, it's taken till now for us to be sitting in this room launching this service. Next slide, please. And then that's the effects, of course, in very brief on the mums, but we must remember that part of our role is the babies, and the evidence is very, very clear of an impact which is absolutely not inevitable and not irreversible on the babies. And just a couple of examples of the impact on the babies: doubling of mental health problems in children later in life from babies who've been exposed to maternal anxiety in pregnancy. Actually, the same applies to depression in pregnancy and the same to anxiety and depression postnatally. It's actually the biggest risk factor we know of, documented risk factor, for these emotional and behavioral problems in children. Next slide, please. And here's another example of a study that looked at prospectively at fetuses, followed them up for 20 years. At age 16, those fetuses, the data was looked at. The ones who were depressed, all of them, 100%, had mothers who'd been depressed, not when these children were 16, but when the children were fetuses. Highly predictive of poor outcomes for the children. But it's not the other way around. Not all children of mums who are depressed in pregnancy will be depressed when they're 16. But it did apply the other way around. The children who are depressed, you could take it back to exposure to depression in the mother. But remember, absolutely not invariable. Most children are fine and not irreversible. Next slide, please. And here's not irreversible. It's a complicated slide, but just to tell you what it shows is that if you have insecure postnatal attachment, you see an effect of maternal anxiety on cognitive development. The higher the anxiety or the cortisol, the lower the development score. If you have secure attachment postnatally, that effect completely disappears. So we can do something about this. And we are the first generation to have this knowledge. Next slide, please. And not only that, but this is a fantastic time for doing that detection work. If you want to detect depression in women, then the peak time to do it is in pregnancy and postnatally. And you can see pregnancy, a third of women in this particular study had depression, which is pretty standard across findings that look at the whole perinatal period rather than just individual points. A sixth in the next year, and a sixth in the 15 years after that. So if you want to catch depression early, catch it in pregnancy. And women are in contact with health services completely routinely. So why haven't we been doing it for decades? Next slide. And we don't do it well. About half of women with depression, it's not detected. And about half of the ones where it is detected get any sort of treatment at all. And about half of those get nice concordant treatment. If this was cardiology, the NHS would be shut down overnight as a non-functioning organisation. Because it's mental health, we've got away with it for decades. Well, no longer. Not in perinatal, anyway. You are going to change that for this population. Next slide, please. And we know why women themselves are reluctant to come forward, and we can do lots of things about that. Next slide, please. And we know some of the strongest risk factors, and we can watch out for those, although there are very few places in the UK that ask about childhood experiences at booking in maternity. But the strongest risk factor we know of for the whole of your health, mental and physical, for the whole of your life, is adverse childhood experiences. And lo and behold, they are the strongest predictor we know of your mental health in pregnancy and postnatally. So if you had a traumatic childhood, then you're more at risk And if you had 6 traumatic scores, ACE scores, for example, you'll die 20 years younger. And in Northern Ireland, I suspect childhood trauma is a pretty prevalent sort of problem amongst the people who are now adults and now reproducing. Next slide, please. And we know through various mechanisms, including epigenetics, which there isn't time to go into, a mother's childhood trauma can have an impact on her child's development. Yeah? And the worse that childhood trauma was, the greater the impact, which is strongly suggestive of a causal relationship across the generations. Next slide, please. And so, just taking all of this data together, what we see, and this is profoundly important to perinatal mental health care, is a complex interaction between childhood adversity, or trauma, if you want to use a short word, and poor maternal mental health that goes from one generation to the next. And I repeat, this is not inevitable, and it's not irreversible, and we can do something about it, and you're going to. Next slide. Oh, I'm running over time. I better speed up. Okay. Which is the most common of these intergenerational problems, and indeed probably the single most common diagnostic entity in perinatal mental health care, complex PTSD. Only been in ICD-11 for 3 years, poorly recognized, and yet, you know, the psychoanalysts over 100 years ago were telling us, although we didn't have the sort of scientific approach to understanding mental health that we do have now, but they were telling us then, look at the childhoods of the people we're looking after in health services, and you will understand. And this remains true, and certainly in specialist perinatal services that I've worked in, about 1/3 of people have complex PTSD, and about 60 to 80% of people referred into specialist services have got histories of childhood trauma and adversity. And probably even more so in other specialities like drug and alcohol services, probably 100% of people have childhood trauma. Eating disorder services, probably 100%. Next slide, please. If you're interested in this area, and if you have any interest in perinatal and you're in this room, you must read this book or listen to it as an audiobook. You absolutely must. You must start reading it tonight, okay? This is the most essential reading for anybody working in mental health. Be you a clinician, be you a peer supporter, be you a manager, this is stuff you absolutely need to understand, and it is a beautifully written book by this Harvard professor of psychiatry. Next slide, please. And then there's a couple of bits of guidance for looking after people with traumatic histories in perinatal specifically, and those are easy to find if you Google them. You'll have the slides at the end. Next slide, please. And this is just to illustrate the complexity of the pathway, to reiterate the role of specialists is to work on the population that they have to serve at the tip of the pyramid, but to support everybody else across the system, just as they are needed to support the care of those at the tip of the pyramid. So unless maternity services are contributing to detecting women with bipolar disorder, for example, the whole system breaks down. But in return, the specialist perinatal mental health services must support those working in maternity to be able to do their job properly with those lower down the pyramid. Next slide. And I'm not going to dwell on this is kind of obvious stuff, but just to say we have lots of evidence base on what the right treatments are. And remember, mother, but also mother-baby relationship and also whole family. Okay, absolutely critical when we're thinking of the range of treatment options. Next slide, please. I'm running very over. Do you want to see this video or not? No, let's move on. Right, yeah. No, move on. Right, and we can move on from that because that's a summary slide for you to look up. Just to say, can we afford it? Is far too much money being spent on this? No. It is not. Physical health care and maternity costs about £3,000 per birth, okay? The amount of money that you guys are going to be spending in specialist services is absolute peanuts compared to that, and it's just about bloody time it was happening. So do not for a moment feel ashamed that this money is being spent. It's about time mental health had parity with physical health, and this is one of the best examples, simple to calculate areas where parity must exist. At the same time, the care has to be delivered beautifully. Next. Next. Okay, and I won't dwell on that. That goes without saying. It costs a fortune if we don't do it. Next. Okay, I'll move on from him to the next bit, and the fingers he's pointing up at you, but he did fund. That's where originally this money came from, and under the Barnett formula also came to Northern Ireland. It just took a while to have a government. Next slide. A government in Northern Ireland that could do something about it. Next, please. Thanks. And the situation across the UK, you can see the green growing. Next. And in England, the green has grown to the extent that we now have no red left at all, but you can see Northern Ireland has stayed exactly the same over that time, and red means access to nothing at all, apart from just in Belfast. Next, and next, and next. And so loads of extra money in England, but now, hooray, money and being spent here. Next. And more's going to be needed, okay? Don't think for a minute this is the end of it, all right? Because we now have a new economic report showing that if we, for the bottom of the pyramid, integrate mental health care into maternity, in other words, mental health workers as part of a multidisciplinary maternity team delivering holistic care, that is not only clinically beneficial, but economically beneficial. Next slide. And, of course, you get that. And I'm going to finish just by saying quality is key. I've already said this. Absolutely critical that you join the Perinatal Quality Network from the get-go, and the quality of what you deliver across the whole pathway will be assured. It's wonderful to see you here. Remember, you have the opportunity of a lifetime to do something truly great in a way that no generation has been able to do. So go forward and do that. Do it together, because working together, you will change the lives of not just this generation, but the generation after and the generation after that. And written on your gravestone will be, this person changed the lives of everybody in Northern Ireland. Thank you.
It's me again. Thank you, Alain. Sorry for rushing you up, and I hope we didn't undersell your product. But we'll get to listen to your video. Just at this juncture, for those who are online in terms of joining us through live streaming, I hope you're enjoying the event and find it interesting. We're running a little bit behind time, and we'll try and catch up as time goes on. There may be one or two questions our audience may wish to pose to you, Alain, and any of the other presenters or speakers, but we'll see what time we've got at the end when Damien is summing up the event. The next speaker gives me great pleasure to introduce my colleague from Ulster University, Professor Siobhan O'Neill. Siobhan O'Neill is a professor of mental health sciences at Ulster University, and she's actually the mental health champion for Northern Ireland. I think that deserves a great round of applause. Her research programs focus on trauma, mental illness and suicidal behaviour in Northern Ireland, and the transgenerational transmission of trauma. She is now on a mission as the mental health champion to improve the mental health of the people of Northern Ireland by promoting evidence-based services and care for those who suffer from mental illness and suicidal ideation. As mental health champion for Northern Ireland, she advises and assists in the promotion of mental health and well-being through all policies and services throughout the provinces. Her role is as a public advocate for mental health and to be a voice for those otherwise voiceless. Excuse me. Her goal is to communicate the collective voices of people with lived experience and their families and carers, and to advocate for communities impacted by mental health inequalities. Siobhan, it's a great pleasure to have you here. Thank you for joining us and making it all the way from Derry. Thank you very much. Some water, Siobhan. Speak close to the microphone so the speakers can hear you.
Okay, super. Good morning, everybody, and it is such a pleasure to be here. Thank you so much for inviting me to speak to you all today. Yeah, that's better. I can see the slides over here now. So do we want to just go to my first? Yeah. Okay, so I'm going to start. My little talk here is about the importance of perinatal mental health services, but in Northern Ireland specifically. And this is something I'm very, very passionate about as a mummy myself and somebody who lives in Northern Ireland, and also then as a result of all the work that I've been doing over the years to highlight the mental health impact of the conflict here, the high rates of mental health problems, and the risk to the next generation. So I'm really pleased to be able to talk to you about this today. So I'm going to start, as all good academics do, with some facts and figures. And this is from the prevalence study that was undertaken just prior to the pandemic in 2019. It was released in 2020, but these are pre-pandemic figures, and I think it's important to point that out. And this study is a representative survey of Northern Ireland's young people, and it found really strikingly high rates of mental health problems in this generation. So 1 in 8 had a mood or anxiety disorder. That would be the most common mental health problems. 1 in 10 had conduct problems. Again, maybe not recognised so much as being related to mental health, but it always is. It's that dysregulation that leads to physiological symptoms. And then 1 in 7 with hyperactivity. There's a clear deprivation gradient, as there is with most things in Northern Ireland, and we find much higher rates in the deprived areas of the province. 1 in 6 young people had symptoms of disordered eating. That was really quite scary for me. Now, that's not an eating disorder per se, but you know, that really rapidly increases the risk of eating disorders. And this is really frightening. 1 in 8, almost 1 in 8, had thought about or attempted suicide. And suicidal thoughts more common in girls and not associated with deprivation there as well. Now, I think the really important point here, and it's great to hear Elaine coming this morning, our rates of mental health problems in young people are still 25% higher than all of the other regions of the UK. Now, in adults, that was the case 10 years ago, but unfortunately the rates in England in adults have gone up there, so the gap has narrowed, unfortunately. But in children and young people, we're still way above the other UK regions, and we've got to ask ourselves what that's about and really take steps to address that disparity. And what we're doing here today, and to launch this amazing service, that's all part of the change that we need here. So next slide, please. Now, again, we talked about this. The biggest risk factor for mental health problems, it's not the troubles, actually, or even deprivation. It's childhood adversities. Of course, living in a deprived area increases your risk of having adversities there, but it's childhood adversities. And you can see there that the most common adversity is actually parental separation, and it's so common to the point that it's not really considered an adversity, but something that's kind of in the normal trajectory of human experience for our young people. But second to that is parental mental health problems. And in this study, that was around 8%. I don't know if you can see the figures there. Yeah, 8% of young people in Northern Ireland have that experience of having a parent with a mental illness. And that's really, really common, really, really high, around 1 in 10. And as we know, again, that increases the risk of having a mental health problem yourself. It doesn't mean that you will go on to develop a mental health problem. And indeed, lots of these adversities actually create resilience. One of the studies we did in our students in 2015 found that in students coming to university, having no adversities, no experience of failure, no hardships at all, actually led to a moderate risk of having mental health problems. So this is so important. You know, our young people need to experience the ups and downs of life, and I think parental separation is probably part of that. But we do need to recognise that parental mental health does increase the risk of mental health problems in that next generation, and it's so important that we address that, because mental health problems are treatable. We know there's so much we can do. So next slide, please. Now, again, this is a really important report that was published a few weeks ago by the Mental Health Foundation. And what they did was they looked at the cost of mental ill health, and most of it's untreated, the cost of mental ill health across the nations of the UK. And in Northern Ireland, this report found that it cost us £3.4 billion annually. In terms, most of that's in lost productivity. Certainly that working age population, cost of providing care to people with a mental health problem is in there as well. And this study doesn't even include the addictions, the mental health problems that are caused by physical health problems that are associated, all of this stuff's interacting. So this is a rather conservative estimate too, but 3.4 billion annually. And we can push that figure way down. We don't quite know how far down we can push it. Right, but the evidence is looking good for the preventability of this stuff. Now, we have a mental health strategy, which I will be talking about later, as I always do, and the cost of that strategy is 1.2 billion over 10 years. So this makes economic sense. If you can even push that down by a third, it would be great there. So let's move on to the next slide. So where should we invest? The same report looked at good buys in a sense of where we should be investing our money for the prevention and intervention in terms of mental health problems. And all of the evidence shows that the earlier we get in there, the better it is, the more money we will save. It's literally money in the bank if we can do the early intervention and prevention stuff properly. Now, the evidence base for this stuff is very limited. So just because something's not in this report doesn't mean it's worth doing. There's lots of theoretical modelling and stuff that shows that anything we do to support people's mental health at any stage is cost effective. It's going to be cost effective. But where we really get a good bang for our buck is if we do the early intervention and prevention. And they highlight stuff like getting the health visitors out into women's homes, identifying at an early stage who's got mental health problems, who are struggling, and getting them to the services. That really will pay dividends. And there's all sorts of other interventions there, really interesting stuff about workplaces and physical activity. But it's really interesting that in terms of treatments, perinatal mental health services is where it's at. That's good investment. And then also when you add on the transgenerational benefit, so it's not just the suffering of the woman. And I think maybe we talk too much about the effect on the baby. We end up making the woman feel guilty and feeling, you know what I mean? And that's not a criticism, but this is not about the babies. It's about the suffering in the woman, which will help everybody around them, including their wee babies, of course, as well. So perinatal mental health services and the health visitor interventions and the early interventions that we do in the stages of pregnancy, all through pregnancy and after the baby is born, really, really important, good investments that we should be making. Right, next slide, please. Okay, so what is mental health? This is a little slide now. I am literally preaching to the choir here this morning, so you'll know all about this. But good mental health is biological, psychological, social, biopsychosocial. That's what I was taught. If I was teaching this now to a group of students, I would also be using the phrase relational. All of the evidence is showing us that, we're not individuals in the way that we maybe thought we were years ago. Our brains are wired in to the brains of everybody else around us. We're part of this huge neurological network. Families, communities, as a society in general, our mental health and well-being is affected by everyone else that's around us, and it's influenced by those relationships that we have in our families and in our communities. And it's chemical, it's a physical thing. It's not apart from that. There's physical chemicals involved in all of this. So relationships are so important. But my goodness, by influencing a woman's mental health in the early stages after a baby is born and in those first few years of life, we're really maximising on that relational feature of mental health. We're improving that. And that's what we should be investing in, the mental health of these women, because they're doing so much in terms of their relationships with other people and keeping everybody around them well. I talk a lot about trauma-informed practice, and it's important to add that we see trauma as being on a continuum where we have psychological safety at one end, and we have necessary stress that we all have, and surely having a baby provides you with enough of that stress. But on the other end of it, we have distress and trauma. And for far too many women, having a baby and being plunged into that situation where you have a wee being that's dependent on you, it's so scary, and it can be traumatizing. It can overwhelm us. And there's not enough talk of that. We know it's stressful, it's difficult, and we have this kind of caricature of the mother juggling it all, but actually for many women, it's a trauma. And there's a physiological thing that happens there as well. So mental health is about understanding the difference between stress and trauma, but knowing that we need to intervene where there is stress and distress and chronic stress and trauma, and that's a feature of child rearing, modern childbearing and child rearing. So, next slide, please. So I talk about these circuits of survival, and we're talking about the impact on the next generation. I think this is quite relevant, this little model, showing there that most of the time we are in safe and social, we're productive, we're creative, we can do the good stuff. And that's where most of us want to be. But of course, whenever there's stress, we get into fight or flight. And when there's trauma, we can even go into shutdown. Now, there's many stages, and it's much more complicated than this. But at an early stage, when that brain is developing, it's calibrating to the external world. So if this is a world where that child's going to need to run away and be very easily activated, then the brain settings are much more easily shifted when that brain's developing. So trauma and adversity in early childhood changes the settings between the safe and social and fight or flight response. So a wee baby who's in that situation, particularly with a mother who's constantly worried and scared, will feel psychologically unsafe. Their fight or flight reaction will be fired off more often than maybe it needs to be, and they're not maybe getting soothed the way they could be. And that calibration then is changed and shifted. And what we can get as a child who has that activation, that hypervigilance, and that does increase the risk of mental health problems throughout the lifespan. Now, because the brain's developing so much, particularly through the childhood years, this is reversible if we get in there. So working with the baby and the mummy at that stage can help get these settings to a state where they really serve that child well going forward. But we need to do it early. We can do it, and neuroplasticity is there throughout the lifespan. But the earlier we get in there to help get these settings right for that child and to help capitalise on that brain development that's happening, particularly in the first three or 4 years, if we can get in there and work with the child and the parent, then we can do so much good to reduce the risk of mental health problems through the lifespan. So next stage, please. Slide even. So I first got into this work when I was involved in the Northern Ireland study of health and stress way back in 2005. I was one of a team of researchers who analysed the rates of mental health problems in Northern Ireland, and we knocked on people's doors. I didn't literally do it. The survey researchers knocked on people's doors. So it was the hidden mental health problems, and this was part of the World Mental Health Survey Initiative's surveys that were undertaken all around the world, over 40 countries. And this, I think, lifted the rock a bit in terms of mental health in Northern Ireland and the impact of the conflict here. Now, in our study, we found that nearly 40%, nearly 4 in 10 people, had witnessed a conflict-related traumatic event. 1 in 5 had seen somebody killed or seriously injured. And those are really significant traumas that do increase the rates of post-traumatic stress disorder and other mental health problems. And indeed, we found then that nearly 40% of our population met the criteria for a mental illness. Now, that included mild mental illness that people get better from without intervention, but we were one of the highest we had one of the highest rates in the world, and we had the highest rates of post-traumatic stress disorder in those days as well. So that was really worrying. Now we presented the work to lots of different groups, and we now have a number of services in place as a result, partly of this understanding that came from this research. So can I get the next slide, please? Despite all the trauma and exposures that we had, most people here were fine, though. And even, we look at this as a little pie chart where we look at the risk of mental health problems and conflict-related trauma. And 70% there, 71% of us were grand or had low-level mild mental health problems. But we have this excess, and back in those days, the rates would have been 14 or 15% in any country. But we had this extra red segment that seemed to be different, and that was related to conflict exposure. And that 4.3%, that group there who had multiple traumas as a result of the conflict and other types of significant trauma had 15 times the rate of suicidal ideation than the blue group. So can we get the next slide, please? So all of this trauma is important to think about how this might impact on mental health and brain development. And the features of PTSD are relevant to this. So post-traumatic stress disorder is characterised by 3 clusters of symptoms. The first one is flashbacks and nightmares. It's a disorder of memory where the event comes back into the person's life in a way that they don't expect it. So they're not thinking about it and they're triggered. So flashbacks and nightmares. Can we go back just one, please? Oh, thanks. And then that can lead to avoidance and numbing and a flattening of emotions. And people with PTSD talk about having difficulty connecting with people because they're suppressing their emotional response all the time because the flashbacks, the nightmares are so significant. So they talk about not being able to express love or any human emotion. And then the third one is hypervigilance. Jumpy, being on high alert all the time as a result of the flashbacks and nightmares. Right, so I want you to think about what that must be like living with a parent who has one of these symptom clusters, or even all 3 together. And our rates of PTSD in that generation were over 8%. The highest in all of the World Mental Health Survey countries. So that is significant, and many, many more people would have had various different symptom clusters but wouldn't have met the full criteria for PTSD. So trauma has a particular impact on early attachment, and attachment is fundamental to good mental health. So next slide, please. So I'm linking here trauma exposure with the ACEs, with the adverse childhood experiences that can increase the risk of mental health problems. Next slide, please. So when we talk about being trauma-informed, there's a shift in the way we think about mental health and mental illness now, and particularly in Northern Ireland. And we're trying to get people to be less likely to label and diagnose and think about what is wrong with you and less about what is wrong with you and move towards thinking about, well, what has happened to you that you're in this situation? So when we're trauma-informed, whether it's perinatal mental health services or thinking about the impact of a conflict, it's all about thinking about what are those experiences that person has had, particularly in their early childhood years, and how has that impacted on their brain development, their stress response pathways, and the triggers that are built in. Next slide, please. So a trauma-informed lens changes what we see, and if we think about applying that to every single situation that we're facing in Northern Ireland, violence, aggression, street violence, there's a fear that's behind that. There's trauma that's behind that. Even the political stalemate that we're in at the minute, there's trauma and fear and threat that underlies that, and we should never minimise that. Withdrawal, disengagement, whether it's a wee child walking out of a class whether it's someone who's withdrawn because they've got PTSD, because they can't make those emotional connections, because it's just too painful for them, because of the way that their trauma invades their everyday life. This is what mental health problems manifest as, and the type of behaviours that we see in Northern Ireland. So what I'm really saying is that mental health, perinatal mental health, attachment, trauma-informed practice, it's actually related to peace in Northern Ireland. It's related to how we're functioning as a society, and we're still seeing the outworkings of that. So next slide, please. So just to talk about parental trauma and ACEs, and nearly at the end of this, you'll be pleased to know as well, it's been a long morning. So what I'm saying is parental trauma can lead to ACEs in the next generation. It can compromise attachment and can impair your ability to meet the child's needs. I have lived this stuff as a single parent. I know how hard it is. You only have to be a good enough parent, and if you're there like most of the time and you do your best, you're grand. But if you're feeling that hypervigilance, that sense of threat, a mental health problem, severe stress, this all impacts on your ability to do that, and it's hard enough at the best of times. But attachment does influence self-regulation, mind-mindedness, mentalization, the child's capacity to read other people, and empathy. And my goodness, we need an empathic generation to get through the problems that we have right now. And we know that if the attachment, and there's areas where this is a real problem in Northern Ireland, but if we can get that right, we'll be making strides ahead in all sorts of areas. And then children model our states. They even model your facial expression, everything. They model that. They feel your fear. They know whenever things are not right. So that parental state is just so important. And children model social violence in the same way too. Right, next slide, please. Super duper, right, go on to the next one. This is just a report. My point is, this next wee bit is the cycle of transgenerational trauma in Northern Ireland. And we first put it together. David Bolton actually was responsible for it and did it in this report that we presented to the Victims Commissioners. So next slide, please. So what's transgenerational transmission? There's a lot of talk about the biology of it, and this idea, this sort of magic thing of a child can feel your pain and somehow know what happened to you. But it's actually much more concrete than that. It's about parental limitations through no fault of their own, impacting on attachment. And that's where it kind of starts a lot of the time. Next slide. And then that influences a child's self-regulation and how they're able to manage their own emotions and their thresholds for that stress response, that fight or flight, and whether or not they get dysregulated, which results in problems for them, of course. And you can see it in our primary schools with some of the kids who have really real difficulties getting there with their emotional regulation. And we're all the time trying to help them with that. That's our one job as parents. So next slide. And then we have relationship and parenting styles that are also affected by mental health problems. Relationships are more likely to break up, and that's kind of an adversity sometimes for children too. And there's a lot of parenting, and there's a lot of evidence that even physical punishment as a parenting style that's adopted in Northern Ireland, and it's more prevalent here than other places as well. So next slide. And then we've got an increased risk of anxiety, depression, and other mental health problems. And we see that there in our high rates in school children. We'll start to see the evidence of this. It's there actually from the age of 4 or 5, and it's certainly there by the age of 8. We see kids with phobias and dysregulation there, but we often don't identify it until they're in secondary school. So next slide. And then, of course, our young people get exposure to alcohol and drugs, and there's so much of that about in our society, and they start to depend on those substances for their emotional regulation. And that creates more problems for them. Next slide, please. And then, of course, they make life and relationship choices that often don't serve them well. Next slide, please. And they can have children themselves at a stage when they're not very well placed to be parents, to do the work that is parenting. It's a wonderful job, and it brings so much joy, but it's hard work. And then next slide, please. And of course, there is that evidence of a biological transmission of trauma. But the good news is that it's epigenetics, which means it's changes to the surface of the gene, chemicals switching genes on and off. And that means it's malleable, it's reversible. And a lot of the work that we do now, we collect biological samples and we look at the changes in methylation patterns following interventions for mental health treatments. And there seems to be some good evidence that the work that we do with babies and toddlers and mummies at that age really impacts on this biological methylation process. So we're now starting to see physically how it makes those changes, and that's so wonderful too. Okay, next slide. In Northern Ireland, keep going with the slides. In fact, complete that. Okay, next slide. Next slide. Next slide. Whoops. So yeah, that wee bit was supposed to be about how the context in Northern Ireland isn't great. We're kind of behind when it comes to family support. We don't have a childcare strategy. Wouldn't that be helpful for all of us struggling and juggling in the morning, trying to get everybody out and, keep the stress levels down? So there's all sorts of issues that continue to impact parents in Northern Ireland that means that it's worse for us here. And we have the ongoing legacy of the conflict, which means that there's still violence in certain areas, and there's still areas and parts of Northern Ireland and populations who feel that they haven't seen the dividends of the peace process and are still going through that sense of conflict that many of us think we left behind, but we haven't really. So we have a mental health strategy. We have a plan to change things generally for our population here. It was created last year during a pandemic, and it was agreed and it was signed off, and it's really, really strong. It includes a whole section on promoting well-being, promoting resilience and good mental health, and early intervention and prevention, which is Action 2 is a plan for early intervention and prevention. So that's something we need to move on specifically. It's not cross-departmental. Of course, it's Department of Health, but that plan will need to be cross-departmental. And arguably, a lot of the stuff is programmed for government work as well. And providing the right support at the right time is in there too, of course. And perinatal mental health services was one of the actions, and it's just amazing that has come through. So when people say there's no point in doing anything, nothing's ever going to change, you hear that all the time. We're always going to be the same here, and it's just going. No, absolutely not. Change can happen, and this is evidence of that, and this should bring us hope and joy, actually, and know that change can happen. So this is the way that I see that we're going to get the rest of the changes that we need in terms of mental health in Northern Ireland. So next slide, please. But we also need other aspects of society to change. It's always a surprise when the slides come up, but I forget what I've put in next when you don't have the computer. So yeah, there's lots of other changes that we need in Northern Ireland. Quality childcare and community support. The awareness of the importance of attachment and early relationships, and how to promote this stuff without piling guilt on mummies and parents and the whole family, and getting everybody to play their part. Early intervention for mental health difficulties, perinatal we've got. Therapy hubs are a really, really important part of this as well, so people can get help. And things like play therapy and arts therapy and relationship and family therapy being available in those hubs is really important too. But that's all in the mental health strategy. So final slide, hopefully. Right, so we have a strategy, we have a funding plan. So not only do we have a strategy, we know exactly what we need to be spending every single year to make this happen. And we've already done the preparatory work in year 0. So we're moving into year 1. The Department of Health have commenced the actions, the preparation for the actions. But we do need funding, and we need about 34% more, which is kind of a nice figure, because that's how that's the difference between what we're spending on mental health and what England's spending. At the minute, it's about 34%. So we just need that top up. We're not asking for much. We just need our level of funding increased. so that we can fully fund this strategy and deliver this strategy so that we can have better mental health across society. But look, it's great to be here today, and this is evidence that change can happen. So whenever you're thinking about what your role in this is, and I know you're doing important work on the ground, a lot of you, but also think about what we're saying to our political representatives and the hope that we have that change can come, and the emphasis now that we need to put on funding this strategy going forward. And thank you so much for listening to me.
Thank you very much, Yvonne. I'm sorry if we've rushed you somewhat. I hope not too many of my students at Ulster are watching, because I know they'd feel if they were over the time that we're over this morning. So I'm not practicing what I preach. Apologies for that. I want to appeal to your cooperation on that score and ask you, just in case some of you perish and need some coffee, if we could have the break now. The caterers have it all set up outside, but if I could ask you, excuse me, to retrieve your refreshments and scones and bring them to the table before the next presenter, Shona Hamilton, I'd be very grateful. And if we could keep it maybe just a wee bit less time than is allotted on the programme for the refreshment break, I'd appreciate that. Thank you.
Folks, just before you jump off your seats, the quickest way to do this is in a one-way system. If everybody would go through these double doors, along the corridor at the end, pick up your tea and coffee and come straight in. And Claire, wherever she disappeared to, if we could have the first row of tables go through there, just pretend you're at school again. Thank you very much.
Okay, everyone, can I have your attention again, please? Thank you very much for your cooperation. Sorry for rushing you up. Hope you enjoy your tea and coffee and scones sat at your table there. So, without further ado, can I introduce the next speaker on our program? Her name is Shona Hamilton. Shona, thank you for your cooperation and delaying your presentation to accommodate our lack of time. So Shona Hamilton has been a nurse and midwife for the past 30 years. She's had a wide variety of posts during that time and is currently a consultant midwife in the Northern Trust with a remit for service development and clinical practice. Shona has been involved in perinatal mental health since 2004, establishing a perinatal clinic in the Ulster Maternity Unit with Dr. Caroline Bryson. Shona was involved in the regional perinatal mental health pathway and the regional group responsible for developing services. It gives me pleasure to introduce Shona to you and give her a nice welcome.
It's a bit strange with the slides. I've got my lenses in so I can see that, but I've got my glasses on because I can't see any closer. When I started this journey, I didn't need any glasses. So first of all, thank you, Victor and the rest of your team for inviting me. I actually feel a little bit overwhelmed. So I know I work in Northern Trust, but I suppose I started my journey around perinatal mental health in South Eastern Trust many moons ago with Dr. Bryson and many other very dedicated clinicians. And I suppose when I looked back at this, I kind of found it quite difficult to believe that we've been at this for 20 years. And now we're here today in terms of services across the region. So it's kind of quite mind-blowing. But I suppose this gave me the opportunity to have a think back. It's a bit like, I'm going to get in trouble because there's a few dodgy photographs in these slides. So Mr. Google was very helpful. But anyway, next slide. So I suppose when I think about the journey, most days look like that very dire, dodgy-looking hill that I've been climbing up in the morns for the last couple of days. But some days, it looked quite hopeful. It looked quite hopeful several times. It looked quite hopeful when we had some people in Stormont. It looked quite hopeful when there was some funding. But for many days, it was difficult. And next slide. And I suppose, why did we start this? And we started this, as Alan said, because women were dying from suicide, was the bottom line. So in 2001 was the first time really that we paid particular attention to the confidential inquiry into maternal death. So in maternity services we're pretty good at hemorrhage and sepsis and shoulder dystocia and all those things that are really physically orientated towards physical care. But what we realised was we weren't particularly good at psychological care. We weren't particularly good at caring for women with psychological problems during pregnancy. So it was quite frightening to us all that the leading cause of maternal death was suicide. That was quite horrifying. And I suppose it was a bit of a wake-up call at that time. And I don't know whether Dr. Lynch remembers presenting at the Royal College Midwives Conference in around 2003, I think, where she was lynched by two midwives, myself and Karen Murray, to say, this is something we need to do something about. And I suppose that's where the journey started out. My mother would have called me Thran. So we marched on, trying to influence and make things happen. And I suppose a great thanks to many people as well. You see Margaret Oates there on the screen. She came many times to Northern Ireland and gave off to a few people on her way. And she was very inspirational. She attended many Royal College Midwives conferences. You know, she did a great job at educating midwives and health visitors and mental health practitioners around perinatal mental health. And at one stage I went to Trinity to do a presentation on lobbying for Royal College Midwives, and there was Margaret Oates presenting on perinatal mental health, and had a joyous whiskey afterwards to celebrate. So, you know, Margaret and Alan and Rock Cantwell and Dr. Ian Jones, all those people across the years have been really instrumental in helping us drive this forward. So and then I looked back 2008, we went and presented to the Health Committee. We thought at that stage we were doing great things. Mary Dugan, myself, Breda Hughes, Dr. Lynch, formally presented to the Health Committee, got ourselves on the Hansard, and promptly didn't really get that much further. But I suppose they were the beginnings of multidisciplinary working. They were the beginnings of lobbying together in terms of Royal Colleges. And then we got the perinatal pathway, and I think that was 2012. I can't remember. My menopausal brain's not helpful at this stage in the game. But and that was a group of very feisty health professionals in a room. As Denise Bolter used to say, professional dialogue. I think some days it might have been a row, if the truth be told. So it started with the women, and that was the idea. And the whole idea as a group of professionals, and next slide, please, you know, these dedicated people did make it happen. And I think it's really important to remember that. You know, so Dr. Bryson started that clinic in the Ulster Hospital with the recognition that these women need added support. Dr. Lynch has always provided care across the region and provided support and advice for the rest of her colleagues, which I think is really important to remember. Karen Murray's there as a representation of Royal College Midwives, and Breda Hughes, her predecessor. We have Mary Dugan, who has been a great friend in terms of Royal College Midwives and Health Vision, but also a great friend in Northern Trust and a great supporter of perinatal mental health services, and the fabulous Scotty, who sat at that table as well, who has always championed the cause in terms of psychological services. And I think it's really important to remember that from a multi-professional approach, you can make things happen. But I suppose we didn't make things happen as professionals. So what was the changing picture of all of this? And I think this is really important to remember too. Next slide. Is that this multi-professional approach needed something else, didn't it? We needed to go further. We needed to think differently. So we did do some key achievements. So I don't see Caroline here from NSPCC. But we did some work with NSPCC around education and what that would look like to midwives and health visitors. We did start regional perinatal mental health training. We started a regional approach to business cases. And we got some excellent modules from our colleagues in UU and Queen's University around perinatal mental health. And so we really started to shape it as a region to give people education and skills and expertise around perinatal mental health. But what made the difference, next slide, is really the women. And Lindsay's not here today, and Lindsay's been a great champion, but I think it's really important to remember the rest of the women in the room. So Tom, going way back, I remember talking to Tom in a coffee shop. At least it was a coffee shop, Tom, and not a bar. When you first went to Aware, and we talked about, you know, peer support and driving forward services for women, and I think that was at least 2004, 2005. And that started, through Aware, started to gather momentum. Tom started to develop some peer support, put together a forum. So we had people like Lindsay, Michelle Bradley, the MAS project, and then that eventually developed in to join in the Maternal Mental Health Alliance. And I think it was the women that made the difference. It wasn't the professionals that made the difference, it was the women that made the difference. Their voice out there, shouting for services that they required and needed was really what pushed it forward. So with the best will in the world, health professionals don't always have the loudest voice. don't always have the opportunity to make things happen, but I certainly think all of those women did. And I say a great thanks to all those women to be brave enough to share their story in the face of huge stigmas around perinatal mental health and speak up and come and speak to health professionals. It's very daunting as a health professional to get up in a room like this, so we have to recognise that sharing a personal story is really difficult and really important. So next slide. So what have we got? So we're in a great position where we have specialist teams in every trust. We have co-production with women who use our services. That's a great coup. We have loads of dedicated, enthusiastic professionals, and that's easy to see when you get a room full of people here to celebrate a service. And I suppose the key for me is the hope for improved care across the region, that every single woman who needs to see a perinatal mental health service professional will be able to do that. And that's amazing, really. So this is where we are, and I think everybody should give themselves a pat on the back for that. And I can't believe we're there all these years later. Next slide. But it wouldn't be me that I didn't just get one last pitch in. So what are we missing? And this is really important to remember. So absolutely celebrate our achievements and celebrate our successes. But remember that Alan showed the map. So we had that lovely map. I used to love putting that map up and say, look at Northern Ireland, it's entirely red, with a little amber speck in Belfast. And now it's entirely green, but it's not green in terms of a mother and baby unit. It's not green in terms of providing women with that support when they're unwell. We still have women admitted to acute psychiatric hospitals without their babies. So this is a really important next step. So this is the next challenge. Please God, it doesn't take 20 years, because by that stage I'll be 72 and I'll be coming in with some sort of walking aid. So I think it's really important that it's, because we're huge now, aren't we? There's a huge amount of people involved in perinatal mental health services. If we can't make a loud noise about this, that is very sad. So next slide. So congratulations, South Eastern Trust. I'm really delighted for you. My heart always lies very closely with South Eastern Trust. I did so much midwifery there, and I have so many friends there. So I'm really proud of your achievements. I'm proud of everybody's achievements, and I hope you're very successful, and I hope you're a very happy team, and I hope you make a huge difference to the women that you care for, because that's the most important thing. So well done. If I had some champagne, I'd toast you. Thank you.
So, good morning again, and I am Damien Brannigan, the Assistant Director for Adult Mental Health Services in South Eastern Trust. And what a great morning we've had already. I'm going to chair the second part of our event today. So thank you to Elaine, Siobhan and Shauna for their wonderful presentations. It is my pleasure to introduce our service user consultant, Eileen Shevlin. Since I took up the role of Assistant Director, Eileen and I have worked together very closely in the spirit of co-production to ensure that the development of our services is guided by a strong evidence base that obviously includes research, but the voice of lived experience is equally important. Clearly, at the launch of our perinatal mental health service, it is important that that voice is heard loud and clear today. Eileen will be accompanied by Dearbhla Sloan, and Eileen will introduce Dearbhla. So thank you to you both.
Thank you, Damien. Before I start, I just want to pick up on something that Alan said earlier, and that's that I'm going to be dead in about 15 years. So as soon as I finish this talk, I'm out the door and straight to the pub, because I suppose I'm textbook for the adverse childhood experiences and the trauma. I've got bipolar disorder and I've got complex PTSD. So, Damien, no more hard work out of me. Just the good stuff from now on, just the team builds. So my role I've been in post since November 2017, and a huge part of my role is to represent the voice of people with lived experience to the mental health managers. I'm part of the mental health management team. But it's not just for my voice, it's to grow the voice at every level throughout mental health. So at a strategic level, I represent the voice both regionally and in trust. Operationally, it's very important that we have a voice as well. And at an individual level, so for people, even things like care plans, it's really important that we have the voice, that it's co-produced. So I play a leading role in the development of all the involvement in mental health and sustaining and maintaining that involvement. So we are lucky because we've got a peer strategy that we have co-produced. It was Damien, Fiona and myself have a peer strategy. And within the strategy is a vision for peer support in all its forms throughout the trust, or throughout mental health, I should say. So within already we have, and started a number of years ago, we have peer support workers in some of our teams. We have peer trainers in the Recovery College, and we have 2 Band 5 coordinators, one who coordinates the Wellness Recovery Network, which is a peer support group that runs in each area of the trust, and the other is a peer coordinator. And then there's me as part of the mental health management team. So we also have volunteers, a large number of volunteers. We have 10 volunteers who are peer advocates who attend our mental health wards for a couple of hours every week, all of our wards. And they advocate for patients who aren't able to advocate for themselves. They also offer peer support. And we have volunteers at our Wellness Recovery Network. We have volunteer partners or co-production partners, and that situation is growing. There was a commitment by the mental health management team in March 2021 that we would have peer support employed in every team, and that we would have grow involvement so that we had at least 2 people with lived experience involved at a strategic level and at an involvement level and for quality improvement throughout the trust. And we've made great inroads with that, but I'm not going to talk about that today. I'm going to talk about why we need involvement. Why do you need us at the table? Well, I mean, for me it's really simple, and I think for most people here it's really simple as well. If you were going to build a house and you got an architect, would you just say, go off there and build me a house? Without consulting, without being involved at every step of the way, without the architect knowing what sort of a house you wanted, what was involved, what rooms did you want, you wouldn't. So why would you not involve people when you're developing the services? How do you know what people need? How do you know? I know that as professionals, obviously you know what we need, and you've worked with us for many, many years, but you don't know my idiosyncrasies. You don't know what's important to me. You don't know what my priorities are, and you don't know what the barriers are for me to be able to live my best life. So that's why you need us involved. Some of the reasons you need us is involved for quality improvement. We need to listen to the voice of lived experience for quality improvement, for quality. We look a lot at statistics, and statistics are really important, but quality improvement is really important as well, and we can only know that by listening to the people who we deliver services to. And we also need, it's really helpful to reduce stigma. The more people start talking about the fact that they have bipolar disorder and complex PTSD, the more it becomes normal. I have a son, he's 15 now, but when he was about 9, he started to tell his friends in the back of the car that I have bipolar disorder. I thought, oh, Jesus. But then he said, and she's helping other people with bipolar disorder to recover. So that's the stigma gone. For my children, there is no stigma with mental health. The other thing I wanted to say as well when I was listening this morning was I have 3 boys. One is 21, one's 19, and one's 15. And I think I should put them on a waiting list now if all the statistics are true, because they're definitely going to end up needing specialist mental health services. Actually, that's a joke, because my boys so far are really healthy and well. So not everybody and not every child is going to be affected by a mum's mental health. So now to get on to the perinatal involvement. I have been involved with perinatal since the very beginning. This has been absolutely true co-production. I was at the table from the very first meeting, and I have been involved in the strategic decisions. I have been welcomed, and I have been made to feel like my opinion and my involvement matters, and also the involvement of other people with lived experience. And all I had to do was suggest, I don't even think I needed to suggest, that we should have the voice of people with perinatal or before perinatal, because at that point we hadn't even started. So lo and behold, we've got a couple of people with lived experience who were involved in the meetings, who were involved from the beginning. I've been involved from the beginning, and we have people are really embraced, and people are made to feel that they're valued. And, you know, that's absolutely fabulous. Just really great example of co-production, and it fills my heart. So I just want now to introduce, and she doesn't need much introduction, but Dearbhla Sloan is one of the mums who's involved, and her husband is here, and it's really great to see that support from not just a mum, but a dad at the meeting. Dearbhla is going to come up now and tell her story. We have other people involved as well at the meetings, but Dearbhla is happy to share her story with us today. So Dearbhla, do you want to come on up?
Before I begin, I'm going to apologise for the shaky voice and the reading off notes. Everybody else was very good at speaking from the mind, but I'm going to stick to script. Number 4, Akshay, you are a pro. I heard this phrase, or at least a derivative of it, in almost every medical appointment I had attended when I was pregnant with my 4th child. Akshay, number 4 will be a walk in the park for you. Sure, you're a dab hand at this now. My hands stung bitterly as I washed them again. It was maybe the 30th time I had washed them that day, and it was only just after lunch. My knuckles were cracking, bleeding as they dried out more and more. Apologies. I was using hand moisturiser, but it was no use. I barely had it on before I had touched or used something that meant I was back at the sink, hands covered in soap and under warm water. A hot, painful rash had spread across the back of both hands. They were burning, painful to touch or move. I was washing my hands not only when I needed to, but every time I felt I had touched something that could be carrying germs. A handle, a switch, the table. To be honest, it was almost anything. I used kitchen roll to dry my hands because I didn't want to use the same towel as anyone, nor did I want to use the same towel twice. In my mind, it was not clean to do so. On top of that, I was also washing all the milk bottles at least twice, and in scalding water, even though they were going to be sterilised. I became obsessed with my other 3 children washing their hands before going near my youngest daughter too. I was riddled with anxiety and fearful that I was going to make her sick, or that I couldn't stop someone else from making her sick. My hands were never clean enough, and the bottles were never clean enough. Boxes of formula powder went in the bin because I worried that they had something in them. I became paranoid that I could see dark spots throughout the formula, checking and rechecking the powder. Bottles of formula milk poured down the sink as I started to doubt how many scoops of powder I had put in. I remember on more than one occasion pouring the same bottle out 3, maybe 4 times as doubt took over my mind. It got to the stage where my husband Aidan made the bottles or counted alongside me as I couldn't trust myself. I couldn't even count to 7 without panicking that I had miscounted, resulting in another whole bottle of milk going down the drain. This was all cemented on top of the already immense feeling of guilt I had for not being able to breastfeed. I tried, believe me, I tried, but I became extremely ill exactly 2 weeks after each of my 4 children were born. This resulted in me being prescribed a range of antibiotics that I wasn't allowed to breastfeed on. With my third child, I pumped and dumped for 2 weeks with very limited professional support, and breastfeeding was no longer in my grasp. At the prenatal appointments during my 4th pregnancy, I raised the fact that I had hemorrhaged exactly 2 weeks after each of my previous 3 babies, and each time my worries were pushed aside and I was told it wouldn't happen again. And it did. My placenta had stopped working with my third child, Fia, and I was just 2 weeks early. Towards the end of my pregnancy with Sheena, my 4th, I was being monitored for reduced movement. She had stopped growing, and then on a visit with my midwife, my temperature, heart rate and blood pressure were all up, and I was sent straight to the hospital with suspected sepsis. Sheena was in just 2 weeks early too. All I could think was, what had I done wrong to put my baby in this danger? Apologies. Why couldn't my body keep my baby safe until 40 weeks? I did not expect to get emotional at all. And why was my body putting my daughter in danger? The guilt was immense, but still, I couldn't ask for help. I had been repeatedly told that this should be no bother to me, and yet I was failing. Wow. I felt like I was letting everyone down. Intrusive thoughts further compounded the guilt. I was going to make her sick. She was going to get sick if I didn't wash the bottles. She was going to get sick if I didn't wash them in a certain way. I know it sounds completely illogical, and the actions or fears that are induced seem irrational. Thank you very much. And the actions or fears that are induced seem irrational, yet my mind would not let me push back against them, convincing me that there would be consequences. It's hard to put into words the exact train of thought induced by these irrational suggestions, and it's even harder to explain it to someone who has never experienced it. Yet it is very real, and if I'm being honest, at times it is very much an internal struggle for myself. I like to think I'm logical, a kind of analytical type of thinker. So for me, the struggle is not only with the anxieties that trigger these thoughts, but also with the thoughts themselves, an inward battle between my logical self and my irrational fears. Rather than speaking up, I would smile and persevere with completing day-to-day activities. But my hand said something completely different, a stinging reminder of the intense and intrusive thoughts penetrating through my mind. In fact, they were screaming for help, screaming for someone to take away the guilt, the anxiety, the overwhelming feeling that I was going to make my daughter sick. I tried to push on through. I had developed similar symptoms when each of my children were born. Although this time it was harder to work through on my own. This time it was much more intense. This time it was impacting harder. And this time it lasted longer. And 3 years later, the scars are still raw, reopening when triggered by something outside of my control. I am lucky to have someone at my side who could see through my painted-on smiles and could see the pain I was holding in. Aidan would take the bottles and fill them so I didn't have to feel the worry. He would reassure me that I was going to be okay. He sat at my side when I tried to breastfeed. He would do anything that would alleviate the worry. He understood why I wanted to put all the kids in the car and go to the shop, a 1-mile drive, with him at 11 o'clock at night, and it was because I didn't want to be alone, even if it was just for 10 minutes. It's good to see the services are progressing in order to ensure perinatal and maternal mental health are prioritised and supported. It is vital that there is an easy access to appropriate and holistic mental health services during and after pregnancy. Every pregnancy, every birth, and every experience of becoming a mum, be it the first, the second, or the 10th time, is different. I struggled more with my 4th child at 31 than I did with my first at 19. Over the past 3 years, I have used writing as a way of coping and talking out loud as a way of overcoming. The narrative that I should know what I was doing made me too afraid to ask for help or to even admit that I was struggling. And although I'm thankful my husband knows me well and could recognise when my anxiety was having such a big impact on my mental and my physical health, I also know there's been a lasting impact and the loosely healed scars are still delicate. Thank you.
Now, I wish Victor was chairing this part, because how do you follow that very brave, very emotional story, not just for Dearbhla, but I think for everyone in the room, and thank you for sharing that. Moving on to hear from the team. Leadership is an absolutely crucial ingredient in the development of a new service, and we are fortunate to have very strong leaders driving the development of our perinatal service in Dr. Carolyn O'Connor, Dr. Riona McCann, and lead nurse Julia Shane. Unfortunately, Riona cannot be with us today. She has taken on well overnight. But Carolyn and Julia will come up to provide us with an overview of our service, discussing the aims, the core functions, and talking about the progress that we've made to date and what the future holds for the team and the service. So I'm going to ask Carolyn and Julia to come up.
Thank you very much, Damien, and oh my goodness, Dearbhla, thank you. From the bottom of our hearts, honestly, you have been just so welcome to come into kind of the service and to give us advice, but to see your bravery and your courage, because I know I'm trembling standing up here. But honestly, it really just is so powerful, so moving, so honest. And let's face it, this is why we are here. This is why we need this service. I've been passionate about perinatal mental health from way in my early trainee days, and I've Dr. Janine Lynch to thank for that, who has been incredibly inspirational throughout my career. And honestly, normally I would much prefer to be sitting right at the very, very, very back watching this. But today, it's a privilege. It's an absolute privilege. I feel blessed to be able to stand here and say that we now have this service and to be part of it. And if you'll indulge me for a little minute, I do want to give a couple of very specific thank yous. And that's firstly to yourself, Damien, and also to Dr. Paddy Moynihan, because unquestionably we would not be here if it was not for your vision, for your commitment, for your forward thinking, for your drive and momentum to enable us to actually have this wonderful multidisciplinary team in front of us. So thank you very much. I also want to convey my big hello to Dr. McCann, who really unfortunately isn't able to be here today, but she is the other half of me in the service, and we work very well, and in fact we work very well as a team, as a whole. Okay, so first slide. Got it there? No. Well, whilst we're trying to work out just the IT, and it was all going far too well, wasn't it? Of course it had to go. But essentially, I suppose, where are we at? Okay, so we have a number, in fact, nearly all of our key professionals in post in the first phase of the service. Yes, that's looking a bit more likely. And we have a beautiful picture of ourselves. We were brought down something like 20 flights of stairs yesterday out into the wind in order to take this picture, because apparently the other one was too blurry. I was quite happy with the blurry one, to be quite honest. So yes, these are some of the key members of our team. We have our base in Ward 10 in the Ulster Hospital, but this is a trust-wide service, so we provide our service throughout all areas of the trust. Our clinics reach out to Downpatrick, to Lisburn, to Ards, to the Peninsula, so that all of our mums can access this close to their home. And that is really, really important. I was lucky enough to be moved across to start up this service about a year or so ago. And in those very early stages, there was myself and Stephanie, who is here. And thank you very much, Stephanie, for all of your work. And then brilliantly, Dr. Michelle Kavanagh joined us. And we were really able to start to lay the groundwork, because that takes a lot, okay? You have to try to get this right. This is a service that reaches across all disciplines, all specialties, and therefore you really need to be thinking about the process mapping and making sure you have those really good, clear lines of communication open Next slide, please. Thank you. This has already been covered, so I'm not going to repeat it. I think the case is very clearly made as to why we need it, and no more so than from yourself, Dearbhla, in terms of why we need this. But this is the leading cause of maternal death in terms of suicide. We know this is the highest risk period, so we have this unenviable opportunity. At no other stage will I see somebody and I know they are entering in their highest risk period. But we do know that with perinatal, so we can plan, we can prepare. We can't always prevent, but we can certainly identify. And if we can identify early, we can intervene early. So even if a relapse happens, then they are unwell for less time and they recover more quickly. We know that there is an economic benefit to having this service, but basically this is about our mums and our babies and our families and improved outcomes. And that's what we're aiming for. Next slide. So this is a step model of care, and the perinatal services sit within level 4. But again, back to what I'm saying, this actually touches on everything in terms of from primary care, health visiting, maternity, infant mental health, our voluntary and non-statutory sectors, right through into our core mental health services. We sit alongside all of the services at the minute, okay? We're not sort of a top-up, top-down. We sit alongside to support, to develop, to train. And I suppose it's really important that we get that message across today. I'm going to hand over to Julia now for the next little bit.
Good morning and welcome. It's still the morning time. I'm very proud to be here today and to be the nurse lead for this team. We're just to give you an overview of our team and who's who. We've got one full-time consultant post which is shared between Dr. O'Connor and Dr. McCann. We've a consultant obstetrician, which is 0.1 time. We've got, I'm the mental health nurse manager. We've got a specialist mental health midwife, which is full-time, a full-time health visitor, 3 mental health nurses, all full-time, a consultant clinical psychologist, 0.3. We've got a mental health social worker, hopefully starting with us in August. And yesterday we just did interviews for the occupational therapist, so hopefully they will we'll find out who has that job by the end of this week. We also have quality and data officer, which is a band 4. So that's the first phase of recruitment in the team. And the second phase is parent and infant psychologist, which is 0.3, a 0.6 of a specialty doctor, a nursery nurse, 1.5 peer support workers, a band 3 administrator, and a patient advocate. Currently, there's also a case is being developed for a specialist perinatal mental health pharmacist. We also have an 8A clinical psychologist who has been appointed as well.
And actually standing there listening to that, you think, oh my goodness, look at the resource, look at the funding that has gone into this. And I know we are at a time coming from, as a community consultant in general adult, I understand fully the pressures that services are under and that the teams are under. So we feel very, very blessed to have this, but I suppose it's again to convey that message that we're here to work alongside and support all of the other current existing services. So I'm going to continue the theme of the morning and put on my glasses because I can't actually see that at all. So essentially just to give you some outline kind of the team in terms of the aims. As you've heard already today, yes, we are developing this in the South Eastern Trust, but this is regional, okay? And those close networking and development of services in each of the trusts making sure that there's consistency, standardisation, so that any woman, no matter where she lives without Northern Ireland, can access and avail of the same services. And that is just an unrivalled opportunity that we have in terms of being able to deliver this. And as for anybody working in mental health knows, between one trust to another, how you refer, how you access services, it's different. For somebody even who has been long in the tooth working in mental health, that is tricky. Whereas hopefully with this, it will streamline it, it will make it actually much more easier and accessible. So what's our aim? Okay, it's primarily about earlier diagnosis and interventions, and that's kind of really what I've touched on. And it's because of the longer lasting impact of this illness when it happens. You want to identify this early, you want to treat it early, you want to improve then outcomes, not just for the mums, but also for the babies and also for the families. We want to provide specialised, holistic and multidisciplinary care. And I think that is really, really important. Apologies, I have a very dry mouth. And actually, I think today you can see, and when you get to meet all the members of the team, you can see that that's what this team is about. It is bringing together a number of multidisciplinary, highly skilled professionals all coming together and working towards the same aim. We want to improve awareness. This does not discriminate. Mental illness does not discriminate. It can affect anybody at any stage. But yet there is still so much stigma around it, and particularly so for mums. And you've heard even Dearbhla very articulately and beautifully describe kind of what that felt like. And that leads people to a very lonely, very isolated place. But would we be saying the same if it was somebody who was presenting with diabetes? Would we be saying the same for somebody that's presenting with a heart condition? No, we wouldn't. So a key role of what we have to look towards is about reducing that stigma, reducing kind of those barriers, making people feel that it is okay to come forward and say they're not okay. Next slide. So we want, basically, there are two kind of key groups. We want to be involved with women who have had a past history of mental illness, who are therefore at higher risk of developing that illness again, particularly in the perinatal period. And we want to be able to identify very quickly those that are presenting for the first time. And as I've said, whilst we can care plan and manage as best as we possibly can, some women will still relapse, some women will still become unwell. But we need to be wrapped around them. We need to identify that and then get in there early and treat it. And therefore, the longer lasting implications are less in terms of the negative impact on them and on their families. Another key piece which probably separates our service out from sort of community mental health teams and more generic services is that we're looking very much at the mum and the infant relationship, or the parent-infant relationship. And you've heard already extensively about how important those early first months and years are in terms of attachment and in terms of breaking that transgenerational cycle that can happen. This service needs to respond quickly. It needs to be accessible to all, and that is, I suppose, when you think of the resource that is within this service, that's behind that. Next slide. We provide a range of biopsychosocial interventions. We have expert, brilliant clinical psychologists. We have obviously a highly skilled team in terms of other psychosocial interventions. There's obviously very specialised medication and psychotropic prescribing, and we have to think about that in the context of, particularly in the antenatal period, you've got a mum and a baby, so you've got two people to be considering. And that requires quite a high level of skill that we need, but that we can offer. We want to promote the mother-baby relationship and getting best outcomes, as I've said, for the infant. And a key piece we're never ever to forget are the partners, the dads, the partners that are just absolutely, and Dearbhla, you even talked about your husband and how important that was for you. So it's really important that we incorporate them. So we're there to advise them, to signpost them, to support them as well, because they're key in all of this as too. And again, it's that parent, so that's the dad, the mum and the baby, all of that relationship together. Next slide. I wish I had made the writing on this bigger, because even with my glasses, I'm struggling to see some of it. Okay, so where are we? So when we first kind of took a post and started to try to roll the service out, we decided, and actually with Dr. Kavanagh, about forming a consultation model initially, because we really weren't in a place where we could actually be kind of taking kind of mums on. So we set up a formal consultation model, which has been really, really well received. So that meant that we could sit down with teams working with mums with mental health difficulties. We would do a case formulation, looking at what kind of the particular difficulties or issues were, and give advice and support. And that is still an integral part of what our service will be. And it is about giving that clinical advice to guidance to a whole wide range of professionals and disciplines and specialties. Training is key. Training and education, we identified from really the get-go, was a priority. So within the South Eastern Trust, we set up a specialised training programme that actually we have now delivered to over 300 healthcare professionals in the South Eastern Trust. And that is to raise awareness of perinatal mental health illness and improve the identification. And once you identify it, then what do you do? And that's something that's ongoing, and actually there's still quite a big demand for that. But that is going to continue on in the months and the years ahead, and actually is a real key part of us as a specialised team, as well as looking at our own training needs within the team is also really important. Another piece that makes us, I suppose, different to other services is that we provide specialised preconceptual counselling. And again, this is all about being ahead of the game. So somebody, a mum who is thinking, or somebody for the first time wants to conceive, who has a history of mental illness, who's on psychotropic medications, what you don't want is that phone call on a Friday at 4:30 and have a mum who's on lithium, who's just discovered they're pregnant, and then it's panic stations all around. You want to plan for this. So we will accept referrals into the service. We will meet with mums, with their husbands, with their partners, and go through in-depth preconceptual counselling with them. And that is very empowering for them. So they're not caught at the point of, oh, I'm pregnant, I don't know what to do, and having to really quickly make a decision. They've got time, they've got space. Quite often it'll be more than one appointment. You'll be bringing them back, they're given written information. And as I've outlined there, it's a really, really detailed assessment, but has again been really, really well received. And I think again it's back to that real importance of planning. Next slide. So that again just kind of covers the preconceptual counselling piece, and obviously the importance of giving the documentation, sending them away, bringing them back, and then seeing where they're at. Next slide. Okay, I'm going to hand back over to Julia.
Okay. So the referral criteria for our team, at the moment we are open to criteria 1, 2, 3 and 7, and in the coming weeks we're going to open to the full criteria. So criteria 1 is women with a past or present mental illness, including bipolar disorder, schizophrenia, schizoaffective disorder, or psychotic depression. We're also taking on women that are currently well, who've got a serious mental illness due to the high risk of relapse in the postnatal period. Referral 2, next slide please, is women with a past or present psychosis in the postnatal period. Criteria 3 is women with a past or present depression that has required acute care or involved a serious attempt on their life. Criteria 4 is other diagnoses such as moderate depression, anxiety or OCD, where there's a significant effect on functioning. So it's impacting on their activities of daily living, their ability to look after themselves or their children, or where there's a purple component to the illness or a significant family history, especially bipolar disorder or purple psychosis on the maternal side. Consideration will also be given to less severe presentations if they have added complexities, such as domestic violence, asylum-seeking status, social deprivation and complex trauma. Women with a primary diagnosis of substance misuse or personality disorder will be accepted if there's a coexisting mental illness. And as Dr. O'Connor said already, women with a history of past or current serious mental illness who are planning a pregnancy and would benefit from preconceptual counselling. Next slide, please. So who can refer? Primary care, consultant psychiatrists, mental health teams, maternity staff, obstetricians, midwives and health visitors. In general, referrals from the maternity staff would initially be discussed with our specialist perinatal mental health midwife, and the referrals from the health visitor would be discussed with our perinatal mental health visitor. However, in their absence, they can be discussed with anyone in the team. The service provides for women aged 18 and over. However, that we would work alongside our colleagues in CAMS to ensure that women under the age of 18 are not excluded. So we'd offer advice and support for those women. The team accepts referrals from 12 weeks gestation up to 1 year postnatal. However, with referrals of women that are maybe up to 10 months postnatal, we would discuss them and make a decision on a case-by-case basis whether they're more suitable for our team or not. How to refer. We urge referrers to take the time to familiarise themselves with our criteria, as it ensures that women are receiving the most appropriate care in a timely manner. For all South Eastern staff, there is a Pacific Perinatal Mental Health referral form on iConnect, which they can fill in and email to the Perinatal Mental Health email address. GPs are asked to continue to put referrals through the Mental Health Assessment Centre so that they still have one point of access into mental health services. Please ensure that the patient is aware of the referral and provide as much information as possible. And just a few specific points is that if there is any urgent referrals, they need to be telephoned on the day. When you're thinking of urgent referrals, you're thinking of the red flags, recent significant changes in mental state or an emergence of a new mental health symptoms, new thoughts or acts of violence or self-harm, and where a woman is experiencing thoughts of incompetence as a mother or estrangement from her baby. For antenatal referrals, please give the estimated date of discharge, or estimated date of delivery, sorry. And any doubt about about appropriateness of a referral, please pick up the phone and speak to the team. If that's just for a query or for advice, we're very happy to help. I'll pass you back to Dr. O'Connor.
Thanks, Julia. Yes, and basically that's the bottom line. You know, if you aren't sure, and this service, it's new, it's just up and running. If you're not sure if somebody meets the criteria or not, we'd much prefer to hear from you and then be able to give advice than for you to not refer in, okay? So I'm just going to finish then with a wee bit of just in terms of where we are at, in terms of the progress that we have made, and then where we want to be. So as I've said, we are still providing formal consultations. So again, those would be for women who you're not quite sure meet the threshold for active kind of taking on of the perinatal team, but still have clear identified needs and difficulties and challenges. So we will provide a formal consultation with the team, and as I've talked about, discuss kind of the case and devise a management plan, and that again continues to be very, very well received. We started at the end of last year with kind of more of the brilliant professionals coming in to post to co-work with mums, with our home treatment team colleagues, and that has really forged very strong working relationships across the trust. And as I've said, we have been offering the preconceptual counselling. We now are up and running, and it's yay, and have an active caseload that is growing by the day. If there's any thought that there's not going to be a need and demand for this service, I can tell you what we're experiencing is actually quite a surge, and there's lots of reasons kind of for that. Next slide. So service development, and where are the next steps? Where is it that we're going to? You've already heard about the importance of actually this all linking together. This needs to link together on a regional basis, and we are very lucky and privileged to be in the position to have colleagues in each of the other 4 trusts. We have Dr. Janine Lynch, who is heading up kind of the regional network, and I cannot tell you how invaluable that support is in terms of helping us to continue to grow and develop the service. As I've said already, we have to continue with education and training, and actually there hasn't been one single case that has come through to our team where there has not been very clear identified learning for us, identified learning from the other teams. So that is really something I'm very passionate about, and we must continue to do. As I've mentioned, we link in with a regional clinical forum, and that's with all of the perinatal teams in all of the other trusts to, again, it's about kind of making everything consistent, making everything standardised, but also making sure we're doing the best that we can with this. And everything, I think, as Dr. Gregoire talked about, this is all driven by evidence base. And we are committed to showing that there is improved, genuine improved clinical outcomes for the mums and their babies, and in terms of measuring that. And actually within mental health, we are quite poor at that. But we actually have a unique position in terms of, from the very start, identifying kind of what are the outcome measures that we want to be looking at, and actually making sure we're capturing that from the very, very start to inform our service, to develop it, to improve it, to make this as best as we can for mums and their families. Next slide. So if we look at Embrace, and obviously, you know, this has already been covered. This is about mothers and babies and reducing risk through audit and confidential inquiries, and there is so much learning that we can take from that. And whilst, yes, we are behind our counterparts throughout the UK, there's also a lot we can learn from what has happened, okay? And we have, I suppose, from the very start in the South Eastern Trust and within the regional kind of network, wanted to make sure we are embedding those major themes and those learnings in how we are developing this service and how we are operating it. So let's look at the structural changes that would help incorporate the learning from Embrace. Well, here we are. We have a community perinatal mental health team, and it's just fantastic. We have created those networks, those regional networks. We are driving forward education and training and the identification of women with perinatal mental illness. And we are, as Shona had already said, we are now on the road to the mother and baby unit. It does not stop here, it does not stop today. Let's look then at individual kind of practice, and it is about reducing the risk of illness and recurrence, and using kind of those specialised skills and knowledge to improve the outcomes for our mums and babies. Next slide. So the other key things which Julia obviously already touched on, which is about looking at symptom patterns and progression, not just doing an assessment in the here and the now and in the moment, holding the overview of this woman's journey and what's been happening to her, knowing and being aware of those red flag symptoms, and we're continuing to provide education and training around that, and looking at kind of estrangement and incompetency as a mum. And that, they are warning lights, they're red flags, and it's about making sure everybody that is aware of that. So how have we tried to incorporate that into the service? Again, it's back to within our multidisciplinary team and the training within that. It's about rolling out training throughout the trust, as I've already said. And we're actually also been linking in with our GP federations in the trust. And that has really been invaluable. Not only in terms of just updating them on the service, but also kind of using that time to be able to provide further education and training. And the formal consultation also helps with that. So it might be that a team doesn't feel they meet the threshold, haven't made a referral in, but think, oh, well, we'll get a consultation. And actually on the consultation, we actually feel, yes, they do. And that we have come up against that. And say, actually, no, this is actually really much more serious than maybe has been thought. Next slide. Other key themes from the Embrace is about grade of assessor. So myself, Dr. McCann and Julia will be doing the first new patient assessments when they come in. And then that is brought to within the team, because this is a multidisciplinary team approach, and it's about utilising the expertise and the experience of all within that team. We try to, in the South Eastern Trust, we don't have a designated liaison service, so this is a slight kind of nuance or difference from maybe some of the other trusts, but we recognise that there can be a very acutely unwell woman in the maternity ward, and we have a duty of care to them. So we have set up that between ourselves and the assessment centre that we will aim to do joint assessments of those whenever possible, and again to sort of front load kind of the expertise at that time, because these are difficult, absolutely, and a number of cases even over recent weeks has really borne that out in terms of really it is difficult in terms of making that diagnosis, but it needs to be kind of there in the front of your mind. We have very close relationships with our maternity staff, and myself and Dr. Bryson go back quite some time, 2009 I think it was, when I got the call when I took up post, and I hear you are interested in perinatal mental health, and we've set up our trust meetings, and they have been running from then actually, and that even predates kind of where we are at now, but we have a really good working relationship with all our maternity staff, really aided by our fantastic specialist midwife Elaine, who is our eyes and ears on the ground and brings that back. But even in terms of the alerting to how you access senior psychiatric help on the out of hours or weekends, and really we've seen how fantastic it is to have maternity staff working alongside us. Next slide. And then the last key theme is around care by multiple teams, and these are all things that were identified that led to very tragic outcomes. And I suppose the key piece of our team is about we have the overview. We hold all of this within our team. We are the wraparound service to that mum and her partner and the baby and the family. But we are also there to enrich to all of the other services around that. But it's about making sure that somebody is seeing the bigger picture rather than it actually just being about the here and the now. Our links with home treatment teams have grown really, really strong, and I have to sincerely thank them for embracing us, for working alongside us. It's never easy when another service kind of comes along and you have to kind of get sort of the policies and the procedures and the ISOs all correct. But actually they've really, really welcomed us, and they've been invaluable support to us. Next slide. And back to them where we want to go. So our next steps. And it is about making sure from the get-go we are embedding meaningful data collection and outcome measurements. And that's to look at service delivery, to look at clinical outcomes, to look at women and partners' experience of care, to look at staffing resources, and that we are evaluating this at every step, and that we are able then to benchmark so that this becomes something clinically genuinely meaningful, okay, for people. Next slide. We're going to continue with strengthening our relationships throughout the regional kind of network, and as I've said, further development of training programs. And the aim is about achieving accreditation in line with the Royal College CCQI standards. It's about that aspirational vision and driving the service for that. There will be ongoing recruitment within the team, and as I've said before, working towards a regional mother-baby unit. Next slide. So really, I suppose just in summary, in terms of specialist perinatal mental health services, I don't think I need to add any more in terms of convincing you as to why this is absolutely vital. This is not a luxury service. This is a core service that should be available to all mums, and thankfully we are there. Thank you. Can we introduce them all?
Thank you, Dr. O'Connor. So, in my previous role within the Trust, I was the lead mental health nurse in adult mental health services. So it's my pleasure to introduce two mental health nurses involved with our perinatal service. to talk about the lived experience reported by some of the new mums who have availed of the service in its early stages. So can I ask Laura Buller and Rachel McCurry to come up?
Wow. Hello everybody. There's 3 CPNs in our service. Unfortunately, Jennifer Donnelly isn't able to be with us today, but I'm Rachel McCurry and this is Laura Buller. And really, we're just stepping up really just to say hello so that you can put a face to the name and just give a really brief overview of who we are and what we're doing. So to say, my name is Rachel McCurry and I'm a CPN in the perinatal team. I previously worked for about 16 years in the acute admissions ward in Ward 27 mental health, and then 18 months with the community addictions team before being absolutely delighted to take up post in the perinatal team in December 2021. And just briefly to say, you know, at the heart of what we do are the mothers and the babies and their families, and working intensively to achieve positive outcomes for everybody. And what this looks like on the ground is being in a really privileged position of families consenting to our input, which is often initially visiting mums and babies on a daily basis and carrying out reviews and psychotherapeutic work, and then reducing the intensity of this in collaboration with the family as things stabilise. It is an absolute joy to be able to see the journey that our mums make in their recovery and seeing their bond develop with their beautiful babies over time and working towards positive outcomes for both the mums and babies as they move forward. It can be very challenging and emotional at times, and I think the team would agree that already we have seen the need for this service because the amount of acutely unwell ladies coming through has really exceeded what we even expected. So really just we're here to do a lot of hard work and a lot of learning and just really embracing moving forward and getting on with it. So thank you, Laura.
Hello everyone, my name is Laura Builder and I'm a CPM with the team as well. I have a 6-year background working within community mental health teams, and I was delighted to transfer over to this role in March of this year. Obviously, Rachel has already said that there's 3 of us in post, and unfortunately Jennifer isn't able to be here today. The development of this service is a very, very exciting time for Northern Ireland, for the health service and for the mothers and families that will be involved with our team. It's a fantastic opportunity to be part of a newly developed team, and I look forward to enhancing my own skills in my future practice, working with families, babies and their partners, and obviously what can be a very challenging time for some parents.
Thank you very much, Rachel and Laura, and hello to Jennifer as well. So I'm now going to introduce Dr. Caroline Bryson, who's consultant obstetrician in the Ulster Hospital, and who has been absolutely instrumental in terms of helping us to get to where we currently are. And alongside Dr. Bryson there will be also Elaine Irwin, who is the specialist perinatal mental health midwife within the team.
Thank you. Elaine, you're not coming up. We do everything together now, so. This is one of those moments where you just want to take a second and go, wow, you know, this is the sunshine moment. This has been, I think some of the words today that have been used, one of the themes has been journeys, and we've been on a journey, and I've been part of the journey for the drive for perinatal mental health services in Northern Ireland for a long time. And I'm delighted with the speakers that have come before today, and I could have sat and listened to our first speakers this morning for much longer, and delighted that everyone's here today and supporting where we are on the journey. I was appointed as a consultant obstetrician gynaecologist at South East Trust in 2002, And my involvement in perinatal mental health before that was practically zero, as it was probably for all trainees who were of my generation within our specialty. When I was training, we occasionally met women who were acutely unwell in the postnatal period with puerperal psychosis. We vaguely knew a little bit about potentially giving them maybe estrogen or something, but we didn't really know, and we didn't have anybody to speak to. We didn't really have a good understanding of medications. We certainly didn't have a good understanding of the obstetric risks that were incumbent upon women who had severe mental health problems and who were on medication as such. And thankfully, through much work, research, etc., the Royal College of Obstetricians and Gynecology have come to recognise that perinatal mental health is actually a specialist area within maternal medicine, and the RCOG very much endorses the drive for dedicated services. And so we are here today. Could I have, is that my second slide? As the lead clinician in the South East Trust for on obstetrics for perinatal mental health, really what I hope to bring to this and what we will bring is an obstetric understanding of the risks and complications and their management of the problems that are presented to obstetrics. We know, for example, that perinatal mental health increases the risk of preterm birth. We know that there is a risk of small for gestational age. We know there's a minefield of risks associated potentially around medication issues. And therefore, it's my role to have that expertise to manage those within the pregnancy setting and to liaise then with the multi-professional team and teams that have been set up. Next slide, please. Embrace has been mentioned a lot already today. I make no apology for mentioning it again. I think within obstetrics and midwifery practice, there was a real wake-up to the risks of perinatal mental health, and I think it was a triennial report started in 1997, where it was first identified that the leading cause of maternal death was actually suicide, outranking all the other, what we might consider the traditional causes of maternal death, such as hypertensive disease, hemorrhage, etc. Next slide, please. No, I really can't read that. If I twist my glasses slightly, I might be able to. But nonetheless, each of the specialist perinatal mental health teams now in Northern Ireland do have a 0.1 consultant lead obstetrician appointed. That's equivalent to 0.1 PAs. That's equivalent to 4 hours per week in our job plans. It doesn't sound like a lot, and everyone who has been appointed to that role also has other roles and responsibilities, but certainly it will be a great help. Can you go back a slide for me, please? Sorry. I can't remember what I was going to say on that, but hopefully you can read it or share my slides later. Thanks. No, thank you. Oh, that's easy. Sorry. Need to go and see the optometrist, I think. So that we're going to establish the strong links with the perinatal mental health team, and then eventually, hopefully, with the mother and baby team, and we're going to be able to liaise then and be an obstetric voice and liaise with our other obstetric colleagues as well to ensure that there is a multi-professional, bespoke treatment plan in place for all our women within our care, and then moving on towards in the postnatal period. Next slide, please. We still have some challenges, and I don't want to say too much on the that's not positive today, because this is a very positive day. But we have to also understand that currently maternity services are set up very differently from mental health services and from perinatal services in particular, in that maternity care in Northern Ireland is not really postcode based. Every woman has a choice of where she births, and the women who may live in one area and may birth in another, or may choose to birth in another area, and that is going to cause challenges for our service and how care is delivered. And there is currently a regional steering group that is looking at that interface, and we have still got challenges to solve within that area, and hopefully we will do that so that there is equality for care for all women, regardless of where they live and regardless of where they choose or have to birth. And also just want to mention about the unmet need within maternity services. Dr. Gregor mentioned this earlier, that those women who do not meet the threshold for perinatal mental health specialist services, we really do that now have to continue on our journey of ensuring that there are services in place and services in place that are embedded within maternity as well, to help those women. So I'd just like to thank you all for coming today and showing your support for this service. It's been a long journey since Shona Hamilton and I started off in 2004, having some extra midwifery support services for women that we identified as need, to actually both being here in this room today. And I'm really humbled to be part of this, and I have to say I am actually proud, very proud. Thank you.
Hi, my name's Elaine. I'm going to stand over here because I don't know if you can see me over this podium because I'm really not very tall. I was feeling okay until I stood up here and was standing up here and looking at all these faces, and I've been getting increasingly nervous as Caroline spoke. My full title is, can I go back a slide? Sorry. Thank you. My full title is up there. I don't very often use it, I have to say, because it's very long, and I tend to call myself the perinatal mental health midwife. I originally trained as a general nurse way back in 1997, and I worked for many years within this trust. And then in 2011, I went back and I retrained as a midwife. And since qualifying as a midwife, I've worked in most areas that midwifery sort of, I think community is probably the only area that I haven't worked in. Initially, I was in the Southern Trust, and then I moved back to the Southeastern Trust in 2016. And I actually think it was around about 2016 that the NSPCC report that was up on the presentation, one of the presentations earlier on, came out, and that's what started. I'd been interested, but that's where my interest really started to take off in perinatal mental health. And then I was very pleased. I took a post in August 2020 within Women in Acute Child Health in this role, which has then recently transferred over to mental health services. And I have to say, as lovely as it was starting in August 2020, it's been lovely to have a team and have some support around me. So it's been great doing that. So can I have the next slide, please? So the role of the midwife, I know a lot of people think that they know what a midwife does and that we deliver babies, but actually there's an awful lot more to do to that. We look at our role as being with women throughout the whole of their pregnancy journey and into the early postnatal period, and we think that this is a really unique and special role. But women tend to remember their midwives, for good or for bad, for years into the future. And in fact, I've sat down in many an evening somewhere, and somebody who's in their 60s has come and told me about their midwife whenever they were having their children. So we really treasure and respect that role, but it also does give us quite a unique a place within this team. And while my obstetric colleagues are the expert whenever it comes to complications with pregnancy and labour and birth, midwives are the expert when it comes to the normal. And really a lot of what our job is figuring out what is normal and to leave well alone, and then what is not quite so normal and when we need to go, Dr. Bryson, I need you, or whoever that is. That's a lot of what we would view our role to be. And that does mean that for many women with low-risk pregnancies, we are the lead and maybe the only professional that they will see for the whole of their pregnancy and birth. And even whenever women have and encounter obstetric care and medical complications within their pregnancy, midwives are a constant feature within that whole sort of antenatal, postnatal journey. So, can I have the next slide, please? Why have a midwife in a perinatal mental health team? And really I set this slide up to show that what I hope this will show is that the women are at the heart of this, and I hope to provide midwifery care to the women engaged in this team as much as possible along a continuity of carer model. Obviously there'll be times whenever I can't meet all of that, but I would aim to be sort of there and build a relationship with them that is supportive and empowers them and enhances their well-being and develops trust. And then when it comes to advocacy, the trust that has engendered in that relationship, that they would have the confidence to articulate their hopes and desires for their pregnancy and for their early motherhood. And then it would also allow me to advocate if they felt that was necessary. As I said before, midwives are sort of a constant within maternity care, and we have then a unique role of being the point of contact between a lot of different services, both mental health, social work and maternity wards, and other services as well, health visiting and GPs, to ensure integrated and seamless care for the women that we look after. And then when it comes to education and advice, we've heard a lot about how much we feel that role is, and I feel as well, whenever I was doing my training, that we didn't have an awful lot of education when it came to mental health, and it really wasn't up to standard probably. So a large part of my role will be providing education and advice in line with my other colleagues in the team, to support my midwifery colleagues to improve their knowledge and confidence in asking about and discussing mental health with their clients. While this won't necessarily directly relate to the women who are engaged in our team, it aims to tackle the stigma surrounding mental health and improve knowledge generally. So thanks very much for your time.
Thanks very much, Elaine and Dr. Bryson. Can I next welcome Karen Elwood, who's Head of Service of Public Health Nursing in the South Eastern Trust, and Ruth Ann Hunter, who's our Specialist Perinatal Mental Health Visitor.
Good afternoon. I'm nervous too. Hopefully I can see the screen, and I know that we're coming to the end of a long morning, but the role of the Health Visiting Service. My name's Karen Elwood. I'm the Head of Service, and I'm responsible for health visiting, but there's also Family Nurse Partnership, Infant Mental Health, Safeguarding Nurses, and New Parent Programme health visitors who all have a key role in infant mental health. And I hope to also outline that we have moved forward, because health visitors have always been involved in perinatal mental health, especially in recognising and responding and doing some therapeutic interventions. But I hope to also outline how we have moved forward and where we are now, and how we support being part of this integrated perinatal pathway. So the Health Visiting Service, the Healthy Child, Healthy Future, which is our framework, it's a universal child health promotion programme in Northern Ireland, so every mum has a health visitor and every mum has a midwife. But we work in partnership with families, and maternal mood assessment starts in the antenatal period. So the health visitor is ideally placed to promote positive perinatal mental health and detect early signs of perinatal mental ill health problems and provide early intervention. So it is a unique and privileged role, as well as the well-established relationship with client enhances and influences the quality of the outcomes. Hot off the press in May, Why Health Visitors Matter. Its publication just published this month, outlining how important health visitors are. In England, the council-run health visiting services have seen a downturn, and they've seen a negative impact on the services for perinatal mental health. So health visitors are an invaluable support, and they have a listening, a trusting, hope and supportive service. Our compliments nearly reflect in each and every one to our health visitor the words, "I don't know what I would have done without my health visitor." To let you know the learning and development that we are moving forward to support the frontline perinatal mental health services that the health visitors provide. All health visitors for a long time now have received level 2 training in the CEC as standard. Our skill mix are trained in the same way at level 1, public health staff nurses and child health assistants. We also have accessed, during COVID, the Institute of Health Visiting e-learning, which is excellent, and that has been a great resource for us when we couldn't access other training. All our health visiting staff, or those who've been off for any reason, the Trust Perinatal Mental Health training that was provided by Carolyn, and all public health nursing staff complete Solihull Foundation, and we are rolling out Solihull Trauma. All health visitors have also received signs of safety and the adverse child experience training. They've also been facilitated to attend conferences like Compassionate Minds and the 2-day multidisciplinary regional training. So all health visitors we have this year been accredited with Breastfeeding Gold accreditation, and that bonding and attachment that is so crucial for perinatal mental health and the support for breastfeeding practice is exemplary in the South Eastern Trust. So next slide, you've antenatal, that's it. So what do we do antenatally? There is routine notification at 25 weeks or earlier if there is a concern or a history of the mum's mental health or vulnerability. So the home contact is offered to all families in the antenatal period, specifically targeted to first-time or known vulnerable mums. A very robust family health assessment is commenced, and that includes routine inquiry about mental health for both parents and also for ex-partners. That maternal mood assessment is standard, so the Wiley questions under the NICE guidelines, and also the use of the Edinburgh Postnatal Depression Scale is part of our clinical assessment, and that will help us have a guided conversation with regard to perinatal mental health and give us a baseline. So next slide, please. All families are seen at core reviews in the first year. They may be seen antenatally, but definitely the primary visit, 10 to 14 days, 68 weeks, 14 to 16 weeks, 6 to 9 months by skill mix or the health visitor, and at 1 year. There are other core contacts after that, but this is the crucial period. The family health assessment remains a live assessment, and there is always a review of perinatal mental health, and the Wiley questions are asked again at least twice. Next slide, please. So our positive responses would be the things that promote bonding and attachment, which is so crucial: breastfeeding, interacting with your baby, the use of Big Start, signposting to baby massage, mellow bumps, mellow babies, parenting groups. We've got tree babies, which is quite trendy and it's really, really popular. Walkie-talkies, other family support that's identified that's unique to the assessment of the health visitor. And also the multidisciplinary team rollout in the GP Federation, which means that the caseloads have now reduced in size, and that gives the health visitor a better opportunity for more meaningful interventions with the family. Next slide, please. When we identify a perinatal mental health, there are health plan targeted interventions and a period of support and structured therapeutic listening visits that are offered by the health visitor. And there is targeted review and intervention. We would liaise with our colleagues, GP, mental health teams, the MDT, mental health support worker, and now the perinatal mental health team, which is just superb. But there are additional services out there that you need to be aware of. We have the ABC, Parent Infant Foundation, Infant Mental Health team. It's unique to the South Eastern Trust and does fantastic work, and that interface between that team and the perinatal mental health team is very strong. The Family Nurse Partnership for mums under 18, very strengths-based, and has got outcomes that are truly fantastic for those young mums. The New Parent Programme, very small caseload for specific health visitors, And we also look to the other agencies of Sure Start, Home Start, family support hubs, our social services colleagues, and any other external agencies. Next slide, please. So what are we doing for health visiting service development? So at this moment in time, we have 6 public health nursing teams. In each team, we have a perinatal mental health champion who has been trained by the Institute of Health Visiting in each team, and that provides the support and advice for the health visitors in the team. We engage with the regional perinatal mental health community of practice to make sure that there's regional consistency in our perinatal mental health interventions. And we participate in the monthly perinatal mental health multidisciplinary team meeting in GP practices to share and disseminate information about the clients within the services, and continue to develop that interface and referral pathways with the perinatal mental health team. Next slide, please. So it's a unique opportunity for the health visitor to be part of the multidisciplinary perinatal mental health team. So we have a specialist health visiting service that will be offered to health visitors, and I'm going to let you continue on there to give you the role of the specialist health visitor. Thank you, Reba.
Hello everyone, my name is Ruth Ann Hunter. I am the specialist health visitor within the perinatal mental health team. My background is approximately 12 years in health visiting and many more prior to that as an adult nurse. I commenced post with the perinatal mental health team in February. The slides on the screen just outline part of my role. As Karen has outlined, health visiting has long recognised the importance of maternal mental health, and it forms a fundamental part of a health visitor's role. With this in mind, the perinatal mental health team offers a unique opportunity for a specialist health visitor to work alongside other healthcare professionals, all from different areas of expertise. My role will be, as well as providing core health visiting service, I will be offering specialist interventions such as the promotion of parent and child attachment and bonding, education with families around infant mental health, and supporting and monitoring of maternal health. This ensures that there's continuity of care for the family, with all aspects of mother and baby care being undertaken by one team. This is a new role, and it will be continuing evolving to meet the needs of this service. As well as my work with families, I will be acting as a link with my health visiting colleagues and the perinatal mental health team. I will provide education and support, and they all know that I'm accessible by phone and by email. I feel like by working together, we can raise the profile of perinatal mental health. I would like to take this opportunity to thank everyone who's worked so hard to create this team. It really is a privilege to work as a health visitor in the perinatal mental health team. Thank you.
Thank you, Karen and Ruth Ann. Next, can I welcome Dr. Michelle Kavanagh, who's our consultant clinical psychologist for the perinatal team.
So they told me to create a presentation for 10 minutes, and I went, no way. So check your watches. It's just coming up to 1. Have a stretch. 5 to 1, have a stretch. And this is probably some of what I do. We get very intense into meetings, and I say, how can we pause? So hopefully my slides are up there. I'm going to skip a few of these, and I want to thank Claire Toner down the back, who's been our steady hand and is our office manager. She's kept us right today. So for my great privilege and indeed pleasure, I work with this wonderful team, and it has been a joy helping you set up structures. And Claire's going to bring up my next slide. When I started out my career over 25 years ago, we had the pleasure of Geraldine Scott Hayes, or Scotty, as I wasn't too sure whether I was allowed to call her that then, inspire us all in terms of infant and mother work. And here we are today, and it's a great joy to be here as a psychologist and with Scotty in the room. But my aim in terms of coming to these services, how can we make sure that psychologically informed care is available at women at the earliest possible opportunity? That it isn't the psychologist in the room, that it's the staff that know how to have that psychological conversation. And that's really what I've been doing. I've been trying to look at what's here in this team, harness it. It harnesses itself, it's infectious in terms of people's ability, and see how we can apply that to assessment, formulation, and indeed intervention. And also, how do we also embed those practices of pausing and reflecting, because there can be an awful lot of chaos and fear around these women in their own lives, their partners, but also systems around them. And how do we ensure as well that we have those tough conversations, but they're done with the tenderness and delicacy, which I've seen this team do very, very well with women and partners in crisis. I'm going to move on to the next slide. I think I remember what it is. Yes, I do. So look, you've heard this today, but what we know, and the thread I want to catch as well, is that mental health problems in family life, they affect children. Indeed, children bear the biggest cost in terms of when we look at health economics. And as we've heard today, there's resilience grown there as well. But what I've been doing in this team is, if we have prompt access to care and we make sure that we're holding the infant and mother in mind and then the family, then our care wraps around all of that. So care should be also provided in an evidence-based way. We have nationally approved interventions. We know what they are. We are growing some in infant mother mental health. That evidence base is a little bit weaker, but it is growing. And now we've seen also today, in terms of systems, that we also need to look at how do we, it's not good enough for women to come into our team in crisis. How do we resource the systems beneath them? So Claire's going to move my next slide on. I'm going to skip that slide. That's in terms of our role. And I'm going to, hopefully it'll speak through this, that you'll see that slide. So how do we do this? We do this together. It's an integrated approach, and that is the gift of this perinatal mental health team to adult mental health services, that we are injecting, and it's lovely to see some of our colleagues from Think Family today, we are injecting that Think Family approach for as early as possible into services. So our formulations are perinatally derived, and what that will mean is they'll always hold the baby in mind. And sometimes it's really hard to hold the baby in mind, particularly for mums themselves, because the stress they're feeling, there's a real preoccupation. Is this going to spill into my baby, into my relationship? But what I've seen is those women's, their own disconnection has been protective. And we wrap around families in those moments of disconnection until they're ready to reconnect, they're well enough. And we've done that very well. There's two key energies in this, in terms of our practice, and one is we anticipate, and then the other one is we act in a very relevant way. So we might have goals of intervention that look like on the ground, this is what we do in this sequence, but then we arrive into a family home and we realize medicine has made somebody very tired during the night and they can't be awake for feeds, and they're really preoccupied. So how do we come in as quick as possible to say, okay, that's a medicine effect. But actually, look at what you're doing now. Look at how you're pulling this in this support. So there's a lovely delicacy in the day-to-day care. And while we say that this service is a step 4 service, today it's a step 4.5, because we are working between step 4 and step 5 to try and prevent women from going into hospital. And we're doing that so well with our colleagues in home treatment team. So I'm going to invite the next slide, Claire, and I really want to mention Claire's name because she's just been a star in the background, and our new friend from tech support in Trinity. So anticipate relevant. This is some of the things we do. And I'm going to look back on these slides in a year's time and go, why did I put that picture there? So on this side we have anticipate, and it's a little doggy waiting for folk to come home. And what we did was, we thought, as Carolyn said, how do we, when we're not set up, the house isn't built yet, how do we start to support the system and at the same time get to know them? So we set up a consultation service. And we did that in such a way that we were using the attachment evidence base. we were in early and often. So it wasn't a one-off consultation service to manage waiting lists or to keep services out. We had repeat consultations. So how do we sent people away with little programs of work and said, come back. And we shored up people's view on what they said was, God, it's a hunch. I have a little bit of a sense of a worry. So we did that little and often, and that harnessed the pathway. The next thing we did was, as our team started to grow, we built in pauses for our own team. If we could serve in return, like the evidence base says in attachment, this team needed to see each other, hear each other, and keep company. And that's what we do. And it's been lovely to see different members join. I remember Rachel coming to visit us and say, oh my goodness, you pause and you connect and you want to know how things are going before we start into the business of the work. Now, just in case colleagues are saying, how much time are you taking for that? We're not doing an awful lot of pausing. It is literally 10 minutes at the start of a meeting. How are you before we start into? And it's so important for these women. How do we improve then parent-infant relationship? And some of what I've been doing is, rather than moving in with a programmatic piece of work, it's attachment-informed, it's trauma-sensitive informed. How do we strengthen a woman's voice and make sure if she's way down the track, having had a purple psychosis and is very depressed and she wants to do skin to skin, because everything is telling her in the literature that's the best for your baby, and she can't do it, we lower expectations. We say, hold that baby's toe for 10 minutes. We bring it right down and we say, that's enough. And notice what that's like. So some of what we've been doing is looking at the evidence base, but also looking at where is the point of access and how do we lower expectations? How do we shore up team relationships so that they are supporting that voice and those skills of pausing and attunement? Because if they're happening in our team, they will be happening when our team visits a mother and baby's home. So, they were pencils, point relevant. Okay, so I think we're coming up to probably my last slide. Yeah, was that 5 minutes? I hope it was. And really, I suppose we are translating hopes here, but they have become a reality. And there have been challenges, but we are really up for that because we're anchored in the same vision. You know, when I've looked at teams regionally as well, because I'm a member of another team, and all the members are people that have a significant amount of skill and expertise. Well, these are new specialist services, and it's just going to be so rich to see how they translate over time. Absolute honour to be here today. Thank you.
Thank you so much, Michelle. That was really uplifting. We're going to finish now with the last bit, and actually, I suppose what I want for you to leave here today with, which is what I think is the most important voice. And we've heard, obviously, from Dearbhla early on, but we felt it was absolutely apt that we close with the voice of some of the mums that we actually have been able to engage with, and that I'm delighted to say have had really, really good outcomes. So a couple of members of the team are going to give just a brief outline kind of their stories. Now, I suppose it's just about being cognizant of the fact that, you know, we're in the very early stages of the service. So obviously our mums are very early in the stages of kind of their journey to recovery. So we have two mums that were happy for us to talk about their backgrounds, and two that wanted to contribute to today, but not to go into kind of specifics about it. And it's obviously just, you know, there's a fragility with it. But we are so, so grateful to them for actually allowing us to bring their voice here today. And I'm going to hand over to Laura and to Rachel.
Hello again. So as part of the mental health team and the perinatal service so far, we've actually already received some lovely compliments from our service and the input that we've had. As you read the quote behind me, Claire. Yes, okay. So you have read it that yourselves, and I will give you some background on this mum's story. So this mum has a diagnosis of bipolar type 1. She was first diagnosed in 2012. As she wanted to start a family and in the absence of the specialist perinatal mental health team at the time, she attended her treating consultant psychiatrist for preconceptual counselling in relation to her medication, which at that time was namely lithium. This was the medication that had provided her with greatest period of stability throughout her life and for a number of years. At the time, and after careful risk-benefit consideration, she made the informed decision to discontinue her lithium prior to conception and to remain off lithium throughout her pregnancy. Unfortunately, at the beginning of her pregnancy, she did experience a hypomanic episode. Initially, this mum was very concerned regarding the effect of medication to the unborn child and was unwilling to commence any medications until 12 weeks gestation. After the first 12 weeks, she did accept to recommence on medication, and however, though she did experience a severe depressive episode which resulted in 2 inpatient admissions, and she did receive co-working from the perinatal mental health team and home treatment team upon discharge, which was very successful. Prior to birth, the perinatal service were able to complete a pre-birth planning meeting, which allowed all of the professionals in this mother's care to come together and to work collaboratively for the best interests of the family. Thankfully, the mother's mental state did begin to improve prior to delivery, and a healthy baby girl was born in December 2021. The postnatal period has been very positive for this family, as the mother recommenced on lithium immediately after birth. And this has been very, very successful in stabilising her mental state, and thankfully her mental state has since remained stable. The mother and baby are both doing very, very well at this time, and they're still currently receiving input from our team, and are very, very fortunate and thankful for it.
Okay, and these are just short statements which we're so appreciative of, testimonials from mothers that are still working with us at the moment. But I have to say, as a nurse just starting in the team, it's just really fantastic to get some positive feedback and think that, you know, hopefully what we're doing is making a difference to people. So the first little testimonial is from one of our ladies, and she says, the perinatal mental health team have been invaluable to us during my ongoing recovery with postnatal psychosis after our daughter's birth in December. As we are unfortunate in Northern Ireland not to have a mother and baby unit yet, I believe this team will be crucial for so many mothers with maternal mental health issues. Thank you for your ongoing support and making our future look brighter by the day, which is really good to hear. And then the second one is really brief but still really positive. That this lady, not mind me saying, she had a previous child and was unwell before our service existed, and consequently has had another child, and things have gone really well, but we've been in very close support. And she says, having experienced postnatal depression after the birth of my first child before the service was established, I have found the support of the new perinatal service to be invaluable. The care and help I have received has been excellent, and that's it. But it's so great to get that feedback, so thank you.
And I'm just going to finish with Joanna's story. So Joanna was one of the very first mums that came into the service, and actually was my pleasure to meet. And Joanna was happy for a wee bit more detail to be given about kind of her story. So Joanna had a diagnosis, or has a diagnosis, of schizoaffective disorder, and had presented actually in 2006, and this was actually, she required admission to hospital, and at that point it was discovered that she was pregnant with her first child. And unfortunately for Joanna, she really did not respond to any of the numerous trials of different medications throughout the antenatal period, and actually had to remain in hospital for the entire antenatal period on special observations throughout, given the severity of her illness and her level of distress. On delivery of her baby daughter at that time, she was commenced on a medication called Dearbhla. This could not be prescribed during kind of the pregnancy because of the teratogenicity of it, and she responded beautifully to it. She really did, and she did really well. And she remained engaged with services since that time. A couple of little blips along the way, but at no stage required home treatment team again or a readmission. Sadly, home circumstances happened that her marriage broke down, and then she presented in 2021 to the outpatient clinic and advised that she was pregnant. There was concern at that time because she was 5 weeks pregnant, she was on Depakote, and obviously there was a lot of worry around that for anybody that is aware of obviously the PREVENT programme. The Depakote had to be discontinued, and we were left in a situation with the mum who had a history of a very severe mental illness, very much in the perinatal context, who's the only medication that she had responded to in the past she could no longer take. So there was a lot of anxiety around for kind of her current treating team. And a key role, I suppose, for ourselves was in terms of stepping in to help support the team in terms of managing that, and as well as trying to support Joanna. And a key piece in Joanna's care was the pre-birth planning aspect of this. So this includes the pregnancy and early postnatal plan, which kind of details her history and detailed the care plan that was to happen at the point of delivery and the immediate postnatal period. Bringing together all the professionals, I think there were 18 professionals came to that pre-birth planning meeting. So that sharing of information, everybody being aware, what are the early signs of relapse, how do we kind of help support and manage that, and what needed to be done in that very early postnatal period. We also then discovered it wasn't just one baby. It was twins that she was having. So here she was, single mum, having twins, this history, and it, was a really exciting time. We all held our breath a little, I don't mind saying. She delivered a little boy and a little girl, very healthy, in the Ulster Hospital, Priya and Niall. And we as a service were positioned in the Ulster Hospital, so able to go over, see her on a daily basis and review things and adjust medication accordingly. And we were able to make sure that she went straight back onto the Depakote as soon as she had delivered the babies, and I have no doubt in my mind that that helped to keep things stable for Joanna. We also then continued to follow her up alongside our home treatment team colleagues in the community. And I am just absolutely thrilled to say at one point we thought, Joanna said, this will be absolutely fine. There'll be no problems here. I'm going to manage this. And I'm thinking, I know what it felt like to have one little baby, never mind having two, never mind kind of all of this. It was an enormous undertaking. But she just breezed into it. And half of us felt concerned about that. And half of us thought, well, she's very positive. But actually, she has just flourished. And it is just a joy. In fact, we nearly argue over who's going to see Joanna and the twins in terms of that. Can you just put up the next slide? Because I want to finish with just this last image. And this is Joanna with Niall and Priya. And they are her absolute life. She's devoted to them, totally in love with them. They're totally in love with her. But it's just such a lovely story, and I hope you can take from that we can make a difference here, and it's not just for one person, it's for the whole family unit as a whole. And with that, because we have gone running over, I just want to say again a massive thank you to Claire and the IT support at the back. Honestly, we wouldn't have got through this without you. 11 o'clock phone calls last night wasn't so much fun. And I just want to thank every single person here. I think, Damien, are you going to do closing remarks for coming today? Thank you.
Thank you, Dr. O'Connor, and thank you to all our speakers today. It promised to be a very special event, and so it transpired, and that was a lovely way to finish the event off. Elaine kicked off the morning highlighting that we have made progress. We're not at the beginning of our journey, but we still have a distance to travel, emphasising the importance of training and education and quality improvement. Both Elaine and Siobhan talked about the central influence of trauma or mental injury, of transgenerational trauma, of attachment and relational issues. Professor O'Neill very effectively conveyed what all that means in a Northern Ireland context, and how some modest investment can reap significant benefit. Shauna then took us on through the journey in Northern Ireland from 2003 or 2004 emphasising the leading role played by many individuals, or indeed a small group of individuals, all of whom I think were women, and I got some knowing looks from colleagues in the audience when that was said. It's no surprise at all that all of our speakers emphasised the importance of perinatal services, but nobody could have underlined that importance more than Dearbhla's very powerful story. But Dearbhla's story also emphasises the importance of the voice of lived experience, driving home what it feels like to be at the end of a service, or indeed not being able to access a service. And that's why Eileen talked about the commitment of our organisation to service user involvement. And we finished with the team giving us an overview of the formation of the service, the roles played by individuals, by professionals within the team, about the family-focused ethos that guides practice, and the range of interventions, the interdependencies and the links between services and teams. Can I just say a few words of thanks to finish up? Can I thank you all for coming along today? It is great to be together in the room to celebrate the development of a service such as this. Can I thank the steering group that I chaired, and in particular Stephanie Patton, who was the project manager, for driving the development of the service. Can I thank Victor Robinson for leading the subcommittee to organise today's event. And can I thank Mark Davison, the facilities manager here at Trinity Methodist Church, for facilitating the event. Finally, I just want to thank the team. I said at the outset in my introductions, I mentioned a number of people for playing a leading role in the team, but you are all leaders. I want to thank you for your commitment, your dedication, for developing the team to the extent at which services are currently available. Dr. O'Connor set out some ambitious objectives for the service going forward, but I am confident, listening to you, that you will be able to deliver in those, and I wish you every luck in doing so. Thank you, everyone. Arrangements for lunch, are they the same? The same organisation?
Yes, folks.